Good morning, everybody, and welcome to the second day of Best of DDW. We had three very interesting modules, and especially what impressed people was the quality of discussion that we had from our side in panelists. Important, very practical for all of us. We hope to continue the same trend. This morning, we have three more modules. The first module is an upper GI. It's going to be Dr. Pratik Sharma, who's going to do the module, followed by a panelist. Pratik is very well known to everybody. Introduce him too much in detail. He currently the professor of medicine at Kansas City, 400 publications, the president-elect of AIG, and so on. So I now invite our panel to start the discussions. Manu, direct the panel. Then we have B.D. Goswami. He's here. Manoj Sahu. Then Venugopal. Raj Ven. Setu. Shobna. And Varghese Thomas. So very high-powered. Sure, we'll have Manu.
One here and the other two there. One can come. Venugopal is coming or Shobna? Venugopal, come. Thanks, Nagi, and thank you both the organizing team. Nagi is here, Randhir and Uday are here, as well as Nanda represents Zydus, whose educational grant has made this possible. Pratik, good morning.
And it's my absolute pleasure to join this annual feature, which has been now set up for several years on reviewing the best abstracts or more clinically relevant abstracts from DDW. My goal will be to provide updates in upper GI diseases from this year's meeting in 2023. I've selected these slides to be reviewed. One is on redo POEM or per-oral endoscopic myotomy, fixation of esophageal stents in the esophagus, the role of PCABs or potassium competitive acid blockers in patients with erosive esophagitis, GI bleeding, prevalence of gastric metaplasia and cancer, and then review the interaction between fatty liver disease and celiac disease. So I will start with this order, moving down from the esophagus into the duodenum for these upper GI diseases. So let's start off for redo POEM. And this was the abstract entitled Efficacy and Safety of Redo POEM after an initial failed POEM, a systematic review and meta-analysis, which was presented. So we know as a background that POEM is a very effective treatment option for patients with achalasia. In fact, it is probably very soon going to be the #1 procedure of choice for patients with achalasia, even as compared to the other modalities of surgery and pneumatic dilation. However, we know that although it's very effective, some patients may still remain symptomatic after POEM. And so these authors wanted to evaluate the efficacy and safety of redo POEM for persistent symptoms after that initial procedure had been performed in patients with achalasia. So this was a systematic review. So they did a search through all the major databases, which are listed here, from time of these databases to November 2022, right before the DDW abstract submission deadline. The outcomes they looked at were clinical success, adverse events, and then also looking at differences in pre and post Eckhart score. Now, as you all know, the Eckhart score is a standardized way of scoring dysphagia in patients with achalasia, and you can compare the score And this is a standardized way of looking at patients with POEM. And then they looked at the pooled rates and the mean differences after these calculations for this systematic review and meta-analysis were done. They found 4 studies with 102 patients, and you can see that the mean time between the redo varied anywhere about roughly a year. And the pooled success rate was 82%, of this POEM procedure, which was done. You can see the 4 studies listed here, and then this is the forest plot showing the clinical success of 82% with 95% confidence intervals ranging from 65 to 92%. They also looked at adverse events, and the pooled adverse events rate was 17%. And you can see that the pooled mean Eckhart score was 5.37 at baseline, and after the POEM or the redo POEM was done, it reduced from 5.37 to 1.63. And you can see that these are the adverse events which are listed there of roughly about 17%, which happened in this study. So the conclusion is that redo POEM is effective and safe option for patients who have persistent symptoms after the initial POEM has been done. However, since this is a study of only 4 studies with just over 100 patients, of course, we need more evidence whether POEM is the initial strategy or other strategies better, such as pneumatic dilation or Heller's myotomy. The second study I'll be reviewing is that of esophageal stenting and how you can fix esophageal stents. And this study is entitled Significant Advantages of Fixation of Esophageal Self-Expanding Metal Stents, a Systematic Review and Meta-Analysis by Vivek and our Kansas City group, which we just presented at DDW. So we do know that the fully covered self-expandable metal stents have a very important role in patients with specific disorders. And these can help dysphagia, they can help fix seal fistulas, but of course they're prone to migration. And so what is a way of fixing the proximal end of the stent, which can reduce migration? So the overall aim here was to see what's the rate of stent migration of these fully covered self-expandable metal stents in which there was fixation either applied or it was not applied in this situation. Similarly, all the databases were searched to identify studies that could be analyzed, and the studies were then grouped into 2 categories. Those undergoing fixation, which were labeled as fully covered self-expandable metal stents with fixation, or the F group, and no fixation, which was the NF group. So these are the 2 groups which were done. The primary outcome was to look at the rate of stent migration, because that's the major thing we are always concerned about. And the secondary outcomes included clinical success, the time to migration, and overall adverse events which were faced in this situation. 9 studies were included, which included 727 patients with 899 or close to 900 stents which were put in these patients. And the reason is because we all know that in some patients, more than one stent may be required in order to palliate their symptoms. The stent migration rate for all procedures was 16% in the fixation group as compared to 33% in the non-fixation group. And you can see that it's almost double or more than double in this situation. When we looked at other secondary outcomes, clinical success, for example, was also significantly higher in the fixation group. The mean time to stent migration was longer. So it's not that in the fixation group there is no migration, but it was longer as compared to the no fixation group. However, the overall adverse events were not significantly different between the two groups. So in conclusion, fixation of these fully covered self-expandable metal stents offers advantages over non-fixation. And in our study, we looked at all methods of fixation, whether it was with the help of sutures, whether it was help of a clipping device, or like the over-the-scope clip which was used. So we included all of them just because there aren't too many studies with any specific one of these devices. And so if the question is which one of this device is better than the other, then it is clear that we do need additional studies to look at which specific method may be better than one method which is used. Moving on from these two endoscopic methodologies of redo poem as well as stents, now let's talk about erosive esophagitis. And you can see that erosive esophagitis is a complication of gastroesophageal reflux disease and is typically treated with acid suppressive therapies. PPIs, or proton pump inhibitors, are the standard of care. However, PCABs are sort of relatively new, which are the potassium competitive acid blockers, and they offer the advantage in which they're able to block acid in the fed state as well as in the fasting state of the patient, so that all sort of proton pumps are inhibited with it. Now, the most commonly available proton, or the PCAB available, is vonoprazan. And that's the reason the systematic review and meta-analysis was done looking at vonoprazan, but there are other PCABs which are available as well in different parts of Asia. Now, we know that this is a novel agent, and it has been shown to result in greater inhibition of gastric acid when compared to PPIs. And so the aim of this systematic review was to compare the safety and efficacy in patients with erosive esophagitis. So databases were searched to look at randomized controlled trials that had reported outcomes of vonoprazan versus lansoprazole. And again, the reason it's lansoprazole is because the majority of the studies with PCABs of vonoprazan have used lansoprazole as the comparator. And this looked at endoscopic healing only at 2, 4, and 8-week intervals after the baseline endoscopy was done and treatment was started in this patient population. Now, subgroup analysis was also done to look at patients with more severe grades of erosive esophagitis, such as Los Angeles grade C and D. So grades A and B are considered as mild to moderate, whereas C and D are severe erosive esophagitis, which were done. 4 randomized controlled trials were evaluated, including more than 2,200 patients, or more than 2,200 patients were included in this analysis. So let's look at the results. At 2 weeks, there was a difference between vonoprazan and lansoprazole, 85% versus 77%. And this is the forest plot showing the differences. And you can see that the pooled analysis crosses that line of 1, which tells you that it is in favor of the PCAB over lansoprazole. 4-week healing was reported in 3 studies only, and there were no differences at 4 weeks, 92% versus 90%. And you can see here that in those 3 studies, the pooled analysis, the line crosses 1, which tells you that there is no significant difference between the 2 drugs which were evaluated. Now, finally, when you look at 8 weeks, what you do see is that it's 95% versus 92%, and it's barely crossing 1, which tells you that yes, there is a significant difference. Whether it's clinically relevant or not remains to be seen, but at least it's 95% over 92%. There are no significant differences in the serious adverse events which were observed, less than 1% between the two groups, and this is the forest plot showing healing at 8 weeks, showing that difference of 95 versus 92%. So based on the data analyzed, vonoprazan resulted in higher rates at 2 weeks and at 8 weeks in this study. So at least there appears to be some numeric difference between the two agents in leading to healing of erosive esophagitis. Now let's follow that same concept, that is more acid suppression better? And using that same concept from gastroesophageal reflux disease, now let's pay attention to GI bleeding. And then this is a study which is presented in preliminary form. And the reason I included this is not because it's something which is a spectacular randomized control trial with the full results, but because it's following that same concept of, is more acid suppression better? And is it better more in the esophagus as compared to the stomach? So this is a study comparing vonoprazan, again, a PCAB with high-dose PPI in recurrent bleeding for patients with ulcer disease who are at a high risk of bleeding. So we do know that we treat patients with ulcer bleeding with PPIs. Now, again, we know that PCABs suppress gastric acidity more than PPIs, but does that translate into clinical outcomes? So this study was to compare high-dose IV PPI to vonoprazan or PCAB in preventing recurrent peptic ulcer bleeding after endoscopic hemostasis has been achieved. This is a randomized, double-blind, and double-dummy controlled trial and standard therapy. Pantoprazole infusion for 72 hours and then followed by oral PPI for twice daily for 14 and then once daily for 8 weeks. And in the other one, they were given either a placebo infusion and oral vonoprazan, which was given twice daily for 14 days and then once daily for the remainder of the 8 weeks, which was done. So a total of 8 weeks. So you can see it's IV PPI followed by oral PPI or just oral PCAB, which was given in this situation. And what were the outcomes? 72-hour recurrent bleeding, 30-day recurrent bleeding, and ulcer healing at 8 weeks were compared between the two groups. So reasonable outcomes which are being looked at in this situation. Now, here's what I was highlighting before, is that this is just the preliminary analysis which was reported, but I think the authors went ahead and reported it because of the significant difference in the results. So what they found was that there was rate of recurrent bleeding was more in the PPI group as compared to the vonoprazan group. And in those without early rebleeding, 66% in the PPI group and 71% experienced complete healing of the ulcers. Length of hospital stay and blood transfusion were lower in the vonoprazan group, but not significantly different. So in conclusion, PCABs did not have better outcomes than those in the PPI group. They were numerically a little bit better, but they're not statistically significant. And of course, we will wait for the final results of this randomized controlled trial, but the preliminary analysis appears to show no difference in this situation. So I think it's important to highlight these because there's no rush for any one of us, at least at this stage, to start having, our patients getting PCABs in any of these situations based on the data that I have presented, at least at this stage. But again, future studies will still may change some of our decision making. Next, let's look at focus on gastric disorders and looking at gastric intestinal metaplasia and gastric cancer. Now, again, in several parts of Asia, there is a high prevalence of these disorders. And this is a study from Thailand looking at gastric cancer and gastric intestinal metaplasia and looking at real world data in this situation for it. So we do know that persistent HP infection is associated with not only peptic ulcer disease, but also with intestinal metaplasia, dysplasia, and gastric adenocarcinoma. So this is well proven. The aim of this analysis from Thailand was to provide prevalence of HP-related infection of these gastric IM dysplasia and gastric adenocarcinoma from a real-world perspective in this situation. So they conducted a large population-based real-world retrospective cohort study. Patients who had an EGD and had been tested for H. pylori, over 5 to 6 years at a tertiary care center in Thailand were recruited, or their charts, were reviewed. So more than 7,000 patients, with 43% of them being men, were included in this analysis to look at that. So the overall H. pylori infection rate was 34%. So I think this is good. It's important to know what the H. pylori prevalence rate is in your patient population that you are treating, because that will determine several other factors of how you test and treat for H. pylori, how you will look for gastric intestinal metaplasia and dysplasia. The highest prevalence was actually observed in a relatively young age group between 41 to 50 years. So that was also a very interesting finding. What they also showed was that prevalence of current infection was significantly higher, or twice as higher, in patients with gastric intestinal metaplasia as compared to those who were H. pylori negative. So 14% versus 7%. And that this was significantly different for both gastric IM as well as dysplasia. And again, this is showing the prevalence between the H. pylori positive and H. pylori negative groups, if you're interested to get more of these numbers between the two groups. So for example, you can look at these differences in the charts of looking at the prevalence according to the age, but also according to the disease or the lesion which was found in the stomach. So in conclusion, an upward trend of gastric dysplasia and cancer was observed. And they say that at least in their population, a test and treat strategy should be done to assist in reducing H. pylori related cancers, because what they did find was that over time there was an increase in both gastric dysplasia and cancer over time. So their thing is, it's increasing. Will eradication of H. pylori decrease this? It remains to be seen, but I think we do need to conduct these types of studies in our patient population to really assess, what's the role of H. pylori in the prevalence of these gastric pre-malignant lesions in the patient population. Now, finally, looking at fatty liver disease and celiac disease, and this is a systematic review and meta-analysis conducted from AIMS in India. And so very interesting results, and I just wanted to share this as the last abstract for this. And this is looking at fatty liver and metabolic syndrome in patients with celiac disease. We do know that there may be a high prevalence of fatty liver and metabolic syndrome in patients with celiac disease. And so what they wanted to do is look at the association between gluten-free diet, prevalence of fatty liver, prevalence of metabolic syndrome, in this patient population, and to do it. So the traditional databases were searched. The primary outcome was the pooled prevalence of fatty liver and metabolic syndrome in those with celiac disease at diagnosis and after a gluten-free diet, which is the standard treatment for disease. They also looked at a secondary outcome of what was the effect of gluten-free diet in this patient population. So 11 studies with more than 2,500 patients were analyzed and included in the analysis. 7 studies reported the prevalence of fatty liver. 6 studies reported the impact of a gluten-free diet on fatty liver, whereas for metabolic syndrome, 7 studies reported the prevalence of metabolic syndrome, and similar number of studies reported the impact of a gluten-free diet on the metabolic syndrome. So this is the methodology and what was done. And here's the flow diagram, which tells you exactly how they identified the studies and how many studies reviewed and then retrieved full text. So similar to what I've just told with that. So let's go on to the results. Let's look at fatty liver disease. So in treatment naive, the prevalence was 18%. And you can see that this is the pooled prevalence. And when they looked at patients on a gluten-free diet, that prevalence, was 28%, so at least numerically higher. Now, when they looked at the impact of gluten-free diet, you can see that it was 15% at baseline in those studies that reported it. And after initiation of a gluten-free diet, it was 29%. So you can see that there is, overlap of the 95% confidence interval between that, but still numerically higher, between that. So this is a representation of the prevalence of fatty liver disease in treatment naive patients with celiac disease. And you can see that's in blue, and then after the addition of a gluten-free diet, what it is shown in red. Now let's look at metabolic syndrome. Now, again, we know that if you look at metabolic syndrome, it's a little bit lower of what the definition included in metabolic syndrome is. So again, treatment naive, around 4%, patients on gluten-free diet, high at 21%. Same concept, if they started looking at the impact of a gluten-free diet, same numbers show up, 4% in treatment naive, and after initiation of a gluten-free diet, significantly much higher, 24%. Now, this is again showing you in a pictorial form the representation of the prevalence of metabolic syndrome and the treatment effect in naive patients, which are shown sort of in blue, and after the initiation of a gluten-free diet, which is shown in red. So you can see the red ones are much more than the blue ones in the So, in conclusion, patients with celiac disease have a higher prevalence of fatty liver disease and metabolic syndrome. So, almost, 20-25% and 4 to 5% at the time of presentation. And this increases after the initiation of a gluten-free diet. So, what should we be doing for our patients? Well, we should screen all our celiac disease patients for the presence of fatty liver and metabolic syndrome. And they should be monitored periodically, because after the initiation of a gluten-free diet, the prevalence of fatty liver disease and metabolic syndrome can continue to increase. And so you should monitor them periodically. So in conclusion, what I've reviewed with you today, and again, this, of course, does not include several hundred abstracts which were presented on upper GI diseases at DDW. And my apologies if I have omitted some of the other important ones, but I thought that these were all clinically relevant. What I've shown you is that you should consider redo POEM in patients who have undergone an initial POEM procedure and have persistent symptoms even after that procedure. For patients in which you place in a fully covered self-expanding metal stent, do consider fixing that stent in the esophagus with any of the methods because it has been shown to reduce the rate of stent migration. PCABs are at the earlier stage of having data around it. I've shown you some results that at week 2 and at week 8, there appears to be some numerically higher rates of endoscopic healing. How this translates in the long run is not clear, and how does it translate for upper GI bleeding is not very clear right now. So no change in practice required, but future data may change the practices for GERD and GI bleeding. At least in Thailand, an upward trend in the prevalence of gastric dysplasia and gastric cancer has been observed. And I think it would be very important for us to get similar data from different patient populations in India. And finally, patients with celiac disease should be screened for the presence of fatty liver and metabolic syndrome. And you should do it at baseline when a diagnosis of celiac disease is made, and also during follow-up when they are on a gluten-free diet. So once again, I would like to thank the organizers who have done a wonderful job with this Best of DDW concept for the last several years, and it was my pleasure to participate. Thank you very much for your attention.
Thank you, Pratik. This is Manu here, this side, and nice to see you live here. It was a wonderful, clear, and concise presentation of the selected papers. I'll just introduce the panel to you. You know most of them. Shobna. Shobna is Mumbai and Jaipur. Setu is from Hyderabad. Dr. B.D. Goswami, Assam. Dr. Sahu, Orissa. Dr. Venugopal, Karnataka, Bangalore. Dr. Varghese Thomas from Kerala. Excellent panel. And what we are going to do is, we have got 35 minutes now. We are going to first discuss with our panelists, maybe request them to finish their talk or their comments in 3 minutes, so that we have 10 minutes for interaction with the audience. And as and when required, we'll revert back to you, asking your opinion on the comments that we are going to pass here. Is that okay with you?
Yes, perfect, Manu. Good to see you and good to see everyone. And hello, everyone.
Yes, so we'll begin. Vonoprazan is a new drug. It is likely to come in India probably in 6 to 8 months. But Setu, I'll start with you. And the first, I'm going to ask you to speak on the first paper which he presented on erosive esophagitis. 2 specific questions. How does it differ from knocking off the PPIs which knock off the proton pump? And what do you think is the potential for vonoprazan in a country like us with the prevalence of EE as you see every day? 3 minutes, Setu.
Okay, thank you. Thanks to you and others. I think we are looking for new drugs because we have enough of experience with so many PPIs that we have, including the devo-rotatory of the original molecule. Way back, omeprazole was compared with other PPIs and was shown to be lesser effective than the next PPI. Similarly, as we went, rabiprazole was found to be superior to the previous PPI. I think this is going to happen. And the new drug, which takes a slightly different pathway, the terminal pathway being sodium potassium membrane ATP, it picks up the potassium moiety and gets blocks and produces reasonable acid secretion blockade, and the efficacy is same. Now look at the studies which I've shown. It is an 8-week study. At 8-week study, vonoprazole is shown to be slightly more effective. Extended to 12 weeks, should they reach head-to-head the same effect? And what we need is a pH 4 and not pH 6 to have a healing. So any drug that produces pH 4 will have the same effect. So I won't think that vonoprazole would make something fantastic, except those people who are sick of prescribing the PPIs those people who are sick of taking PPIs, they say, suppose you write one particular drug, he says, sir, I've been already taking. And you will always see prescriptions of 5 people, and they're already there, all 5 are there, and then you look for a new PPI. I think that will help you. And I understand Takeda is doing their best, and the files are with DCGI, and probably it will come in about 6 to 8 months, and you will have your own experience. Two components. One is that it doesn't make a major difference in GI bleed because the mechanism of action of being same. And I just want to recollect one very nice paper in NEJM which compared PPI with sucralfate, and sucralfate may be superior to conventional. Or together they may be more efficacious. But our tendency in real-time practice is that we try to give them PPI and then give them sucralfate, and on an average we are comfortable than the. The third point that we were probably looking at the side effects of vanaprazole. It also has a similar side effects like any of the PPIs. And one paper which actually talked about it is the interstitial nephritis, which is one of the important things which are actually not recognized by many of us. Because what is happening with PPIs is we write for 12 weeks, but patient goes into a demand mode, or he goes into an intermittent mode. This was discussed a number of times. I think Dr. Shobna remembers one paper presented in API by a consortium of people who decided on PPI's usage in India and its side effects. The last point is, surprisingly, even though we talk so much about, there is a nomenclature called pre-prescribing and de-prescribing PPI. We are talking about de-prescribing, the major article in gastroenterology. So all of us are trying to de-prescribe the PPIs, and then probably vanaprazole would be prescribed in those areas.
I have one question either for Setu or Pratik. Now, PPIs we knew produce irreversible, shutdown of the P, and new pumps were formed, and its duration of action. So, what about vonoprazole? Irreversible closure, and how long does it act?
It is actually whatever irreversible is temporary irreversible. You have
Okay,
two
so it
phases.
comes back
Yeah,
again, not
you-
like PPI.
That's why we talk about nocturnal acid breakthrough, which is actually some of the reactivation of the pumps which secrete the acid.
And time, once a day would be enough?
Once a day would be enough. But you would know that we had some hard lessons that PPI PD is better than. So tomorrow somebody might produce a paper. There is another one small paper which is added very quickly, is that you can use post endoscopic procedures. And there is one paper which has used in ESD that this seems to be more effective than PPI.
Okay, quick comment,
So
BD,
Manu,
then we
also,
move on.
quickly,
Yes.
Manu, is
Yes.
the fact that it all depends on the molecule of the PCAB. There is another PCAB which is available and is being studied in Scandinavia, which needs to be given twice a day rather than once a day. So I think the duration of action of this is not any longer than the conventional PPI. So it all depends on the molecule which is being evaluated. Vonoprazan is once a day, but there are some PCABs which may be required to be used twice a day.
Thank you. BD, quick comment, please, then we move on.
You already published and on here that 2 weeks, 4 weeks, or 8 weeks of vonoprazan. But the question about the maintenance therapy erosive hepatitis, because most of the time erosive hepatitis, once it is treated, after that symptomatically they persist and it for the maintenance therapy. Question mark about the safety of using the
Long term.
vonoprazan for a long time. Because in our place, for example, used to get the PPI, people are taking it for even 12 years, continuously taking it without consulting a. That is the concern point probably.
Let's say to take that up, safety wise, safe.
Yeah, I think if you look at the patient population, they won't take very sincerely every day because of the long duration of symptom relief more than healing. That is why the end point of any of these inflammatory diseases is endoscopic healing rather than symptom relief. Symptom relief is achieved very fast.
Let's ask Pratik, how long do you use it initially, Pratik, and do you go into a different maintenance dose?
Yeah, so in the US, I mean, so this specific meta-analysis just looked at 8-week healing, but recent studies in the US have looked at 6 months, 8 months maintenance, what BD is talking about. And the maintenance of erosive esophagitis with the PCAB is very similar to the PPI. Now, from Japan, where vonoprazan has been available for more years, for at least about 5 or 6 years, at least that data in Japanese patients for about 5 to 6 years shows that there is an increase in the serum gastrin level, which persists over long term, but the patient-driven side effects are also very similar to PPIs only. So that's what we can say right now. So to BD's comment, we obviously don't have 15-year, 20-year data like we do with PPIs, but we have sort of the Japanese data for about 5 to 6 years of follow-up.
Okay, thank you.
Can and
I
can
think
one
we'll
more-
move on. Okay, very
one
brief then.
very
We are
quick item.
running out of time.
So it is also used in triple therapy and dual therapy for H. pylori eradication. That also moved forward.
Manoj, we'll come to you next. You saw endoscopy. From drugs, we'll move to endoscopy. Fixation of SEMS, common problem. There's only one comment I'd like you to address in Pratik's presentation. The migration rate without fixation was 32. We, on an average, I think we have got champions sitting in the audience, probably think about 20 as the migration rate. So one, I want a comment on that. And then what is your comment, as well as if you have any personal experience on fixing CSEMS or SEMS?
Thank you, sir. In this meta-analysis, if you see, so the fixation group, the state migration rate significantly lower, 16% versus 35% what you described. And the clinical success rate is significantly higher, but there is no adverse event between two groups. But if you see in the subgroup analysis, also in this meta-analysis, the group which undergone suturing, significantly lower stain migration rate. But if you ask which is better between OTS clips or suturing, no good information because you do not have good comparative study. There are various methods of fixation described even in our country, like putting through the scope hemostatic clips, external fixation at the near or ears, or over the scope OTS clips, both conventional and now the new age stent fix, which is specifically designed, and the endoscopic suturing. But it appears that OTS clips, over the scope clips, and endoscopic suturing seems to be the better modalities. If you describe about stent fix is the novel and the specially designed over the scope clip for this purpose. There is a comparative study of stent fix. If you see, the stent migration rate is significantly lower, that is 8% versus 35%. Now the question of Manu sir is 35%. What is our experience in our country? It is between various studies from India, again between 20 to 30%. So endoscopic suturing, again we use Apollo overstitch, but endoscopic suturing, during the putting the suture, we should avoid the area which has mucosal compression, mucosal depression, by and the visible pulsation should be avoided. There is a novel method described from our country, from Delhi. So what they did, they put vertical mucosal incision like what we do in poem. Then they put the clip, Boston clip of stent and the mucosa, and they found that is effective. That also can be tried. So the migration is there from India. Study is 20 to 30%, but definitely this meta-analysis is such, and various other studies also. So if you're putting a fixation device, definitely prevent migration, clinical success rate is more. But which is better? We need comparative study. But over the scope, the new thing is stent fix, which is a good stent, specifically designed circular stent, and the suturing also is coming. So these two can be done.
Here, let me add our own experience. Radhika presented a paper, OTSC, in which out of 36 patients, 9 were, the paper was on OTSC. 9 of them were the fixed type, and all of them were followed up for 3 months. X-rays was done to see migration. None of them had a migration. So it is a good device. Would like to just one quick word. How much is the migration rate in general with covered stents? Say for esophageal, we are only talking 20%. Any other varying, Randhir? Malignancies. Because the stricture holds the growth holds the stent. Yes, quick comment then. We are coming back to you anyway.
Pratik, unfortunately, the abstracts are not reviewed, and the statistics has gone for a toss. The stent migration, the rates were different, that's statistically significant, but the duration of migration, one was 39, 31, and the standard deviation was 12 and 11. So with such a standard deviation, you don't have a significance. So it doesn't matter whether it's out in 20 days or 10 days. Does it matter?
Pratik, he says the statistics were skewed.
No,
Yes, so I
unfortunately,
think
they're not reviewed.
so the issue is that the point to make with this is that if you're putting in a fully covered stent, it is probably better that you try to fix it with some modality, because
Okay.
otherwise the stent migration rate will be higher in that group. And I understand what he's commenting on the statistics, but I think it is statistically significant between
Yeah,
the two.
I will add up to that. Pratik, I'll add up to
Yeah.
that. The reason is obviously you had small number of. Now, obviously, the studies were very heterogeneous because I did not see the I square being presented, but I looked at the forest. It looked like these are heterogeneous. I'm sure they would have done random effect model rather than the fixed model with such heterogeneity and small. When somebody has done a random effect, and in spite of the heterogeneity, we have accept the p-values because the statistically this is 10K. Only thing is that look at the variability of the different studies. Some odds ratios were little higher side, some odds ratios too low. So that means we need a meta regression here to find out what is the reason for this variability. It is quite possible in some the stent was done in a non-occlusive lesion, more migration. In some stent was done in a lesion, less migration.
We'll keep the audience participation to the end. Pratik, we'll take that up again at the end if you don't mind. Move on to the third, which we are still, BD is there and it's an endoscopy topic. BD, your experience, maybe your center is not doing now. He talked about redo per oral poem. Comments on that? We have got experience. I may add a few words, but what are your comments on redo poem in all those conditions? He's talked failed poem, but we can also include Heller's and balloon dilatation.
Yeah, point is for echinacea, the line of treatment is already established, and at the same time we have got the poem coming to the picture in 2010. So long-term data already we have got today. And on principle, poem has got a success rate around 1%. Some percent. And then we have got failed poem coming up now. So the question is, what is next if the patient has got the failed poem? In this respect, we have got so many publications. Most of them have established, yes, when you go for them, really effective one. So this Pratik has already shown in the studies clearly to the poem or redo poem. We have got the publication from different countries, from European countries, US, and from Asia. It was reviewed, which was published in the endoscopy reviewed by Sharma. In 16 centers, they showed that yes, from these countries, the redo poem is equally safe and equally effective one. They compared, in that study, they compared a conservative treatment for achalasia. It compared with the redo poem. Then also it compared with pneumatic dilatation and also Haller's myotomy. But it is shown that 76%, 60%, 76% in pneumatic dilatation, 60%, 76% it was in poem, redo poem, 60% in pneumatic dilatation, and conservative treatment is 36% success rate, and Haller's myotomy is around 29%. Then again, the studies coming from France, published in 2020, showing similar picture of going for the poem, redo poem, that is also equally safe and equally effective one. Then they have got some publications from Japan as well as the German, that they preferred to go for probably the Haller's myotomy instead of going for redo poem. So all these studies ultimately showing, even in AIG, they have got the publication of redo poem equally safe. But China, they have got one publication recently, World Journal of Gastroenterology. The Chinese study, they showed that yes, redo poem, it is equally effective, definitely, but at the same time, they tried with redo poem plus simultaneous subcutaneous, submucosal and muscle dissection. They also say procedural alternative to redo poem. So we have got the different publications showing the different ways, but redo poem is really effective, success and safe procedure for achalasia.
Thanks, BD. Our own experience, we have got a wonderful team, Mohan and Zahir along Pradev and all. We'll keep the audience for later if you, we'll do it a little later. Okay, so that I talked to them personally because that paper is under publication. 75 patients redo in all the three. There were 30 with redo poems also. Following a first poem, others were Heller and balloon. The commonest cause of failed poem the first time they say was the initial learning curve, when the length of myotomy was not big enough, especially gastric side. That is purely because of fear and inexperience. As they gained confidence, the length and the depth of the cut became better and better, and the failures have reduced. They are publishing it. The data is excellent. So all the three things, Heller's, balloon, and a failed poem, redo poem has been effective. Okay? Yeah, very quickly.
Did they do at the same site or?
They did both. Fibrosis depending on, but mostly others. Venu, Raj, we'll come to you. Setu has talked to us about KCABs in EE. Now, Pratik told us meta-analysis on rebleeds. Your opinion, and I know the drug is not available from whatever you have read in literature.
So I think PCAPs has been found to be, various data has been available for its efficacy superiority of this drug over PPI in various conditions like erosive esophagitis. It has been found to be useful in triple therapy. The superiority has been shown in eradication of H. pylori, and even ESD and other procedure-related bleeds have been less with PCAPs compared to PPI. So in this context, we don't have much data on actively bleeding ulcers. And this paper highlights its effectivity on bleeding ulcers. But it is important to note here that in spite of using an oral preparation compared to a IV preparation, as we know, during bleeds, the pharmacokinetics can be different, the bioavailability or oral absorption can be affected. still using an oral pitched against an oral preparation, and that too at a very low dose, equivalent dose. Like they've used almost 200 milligrams of PPI versus 40 milligrams of this thing, which they found superior. So might be looks like it is going to be promising, but whether we need such a strong drug is something which needs.
No, I think that's an excellent point. The presence of an oral drug, Kuru's paper where he said Indian population, low parietal mass, oral omeprazole is as good. If vonoprazole orally can be as good or better, then I think it's wonderful. It's like all the drugs that we use in IBDs, we are switching over from parenteral to oral drugs. So that will be a wonderful thing. Pratik, we feel that the oral component, even if the efficacy is marginally higher, the oral effect, if it is as good, will make a great difference in management.
Yes, I think I thought that part of the reason I presented that because it's also a very short or a very small study. They did an interim analysis. So we have to take the significance between the two groups with a grain of salt right now because we don't have the full results. But the key is, just as was mentioned, is that they're comparing IV versus PO. And then if there is, even if there is no difference between the two, the PO or the oral component may be good. On the other hand, I think we still have to keep in mind that some of these patients with GI bleed may be nil per mouth or NPO initially. So you may have to give them something IV, but then you can switch them to a PO drug very quickly.
Thank you. Shobna, Thailand study, gastric cancer, metaplasia, H. pylori. Your comments on Indian population. One comment, their prevalence rate is 34%, point something. What do you think is our current urban and rural prevalence rate? And the same, do we have an increased incidence of metaplasia and malignancy?
So first is regarding the prevalence of H. pylori. It's still varying between 40 and 60% in various parts of the country. The thing is that it depends on how you are diagnosing H. pylori. Most of our patients who come for endoscopy are already on PPIs, and one or two pieces of antral biopsies are taken, and both these are going to underdiagnose the H. pylori, because if a patient is on PPI, the H. pylori is going to migrate to the body and the fundus. Secondly, RUT itself, the commercially available, they say that it should be, the test should be observed at 24 hours. At 24 hours, we know that there are going to be many contaminants which will also cause H. pylori positive. I won't go into the detail of that. So diagnosis of H. pylori by RUT has its problems, and therefore I think we need to move away from that. Secondly, coming to the main part of this study is that intestinal metaplasia and gastric cancer in Thailand. This is a large study. The only thing I couldn't find is where they took the biopsies from for the intestinal metaplasia and dysplasia. So that was one of the things. But having said that, I think they did show that H. pylori was highly associated with metaplasia, about 10% of patients, and no, that was 14% and 7% in patients without the H. pylori. So that is a significant difference, but at the same time, it tells you that some patients without H. pylori will also have intestinal metaplasia. It is not like there is no metaplasia without the H. pylori. Coming to Indian studies, there are very few studies on the prevalence of intestinal. However, there are studies on looking at patients with intestinal metaplasia, especially with gastric cancer. And one of the studies is where they looked at the PG2 polymorphism, the PG2 levels, that is the pepsinogen 2 levels, and found them to be higher in patients with H. pylori positive, intestinal metaplasia, as well as in gastric cancer. So that does tell us that yes, there is intestinal metaplasia in our population. Now, the most important question that comes follow up of this, whether we should be treating all the H. pyloris who come. That I think is a bit of an overkill. The issue comes up when a patient comes, we diagnose him as H. pylori. Patient comes and says this is a class 1 carcinogen as prescribed by the WHO. Why don't you treat me? But the evidence to treat H. pylori in our country is yet I'm not confident of saying that all these patients, and that I would stop at. I think this is a study that all academic centers should take up to
It's been
find
a
out.
debate for long.
Yes,
It's been a debate.
yes, but I think that given that there are many academic centers here, take up patients with dyspepsia, find out H. pylori and intestinal metaplasia, not just H. pylori positive.
So
and
Manu,
forget
I just had a quick comment for
Yes.
Shobna. So
Thank you.
Shobna is saying we should not be treating H. pylori. So Shobna, why is it being tested for then if you don't want to
So
treat
that
it?
is the whole problem. Testing has become so routine, and there are many people who do not test for H. pylori in India.
Right. So I mean, there is evidence, as you know, that for non-ulcer dyspepsia, that there may be some benefit in treating for H. pylori, and that it can even up to 12 months improve the symptoms. So I think if you're waiting for studies, that is fine. But if you test it, then it is positive. I think then you should probably be treating it, but because otherwise, why are we even looking for it?
No, so that's what I said, that once you test it and if it is positive, before we treat it, the patient asks for the treatment, supposed to treat. So yes, we do treat them, but I don't think anybody looks for eradication, whether the eradication was there or not. And many of the available kits are not having the complete doses. So I won't go into those controversies, but I think this is something that we need to look at. Yes.
Setu, then we'll come. BD, after the last one, we'll come. Setu, quickly, because I have to ask, work is something new.
You've been asking questions. Can I ask you a question?
Okay.
What happens to your colonoscopic biopsy of H. pylori?
I have never done one. Never done one. Contaminant, I would have written, if it comes.
It wouldn't have been contaminant because it's a biopsy.
Okay.
So there are a lot of stories, and that's why we call it rapid urease, because we want to read as early as possible. Number one, we look at stool antigen as probably a better marker than just a mere presence, but we'll present our data probably in the next ISG, what happens to this.
Okay. We
and
are
its
quickly moving on. BD, after this. Varghese, since this is the last paper and we have some time for audience, Govind is here, so we can direct questions after you to him only. He is one of the authors. So celiac disease, gluten-free diet, metabolic syndrome, NAFLD. Your comments, your experience.
Well, this paper is from Professor Govind's unit by Nitin Agarwal. This is a meta-analysis on patients with celiac disease before treatment and after treatment, gluten-free diet. The prevalence of NAFLD as well as metabolic syndrome before and after treatment. And 11 studies were included and around 686 patients were. So we have a robust data. What they found was that the prevalence of NAFLD was 18.2 before treatment, and after treatment it was 28.2. And similarly, the prevalence of metabolic syndrome was 4.3 at the beginning and very high value, that's 24.2 at the end of treatment. Okay. Now, we were considering celiac disease as a different disease of malnutrition, undernutrition. So if you look at the literature, this study actually they have taken studies from 1990 onward, I mean 3 decades. So prior to 2000, most of the descriptions or literature on celiac disease were like a disease with a chronic diarrhea, malabsorption, micro and micronutrient deficiency. And if at all fatty liver was there, it was probably not investigated in detail, and it was all considered part of the undernutrition part. Our interest in fatty liver disease came probably, a lot of interest is after 2000. Okay, so more detection of fatty liver. And second, from 2010 onwards, there is a widespread availability of the testing for celiac disease. So there are things which have improved over a period of time. So from a disease where malnutrition or undernutrition was the pattern, now we are detecting cases which are normal weight or even obese people. So this is from a classic, so this disease has undergone a paradigm shift. So from a classic disease with chronic diarrhea, malabsorption, underweight, low BMI, we are seeing patients with a normal weight and even obese people. Okay, this possibility, why we are seeing such people? Because probably we are detecting milder form of disease because more ability to detect disease because of
widespread availability of these lab facilities are there. So we are detecting less classical disease or non-classical more often using this test. So probably we are detecting the non-classic variety of celiac disease often. That may explain why we are finding increased prevalence of metabolic or fatty liver in de novo patients. The second part is while on gluten-free diet, they develop again fatty liver, exponential increase in the all the features of metabolic syndrome. Why it happens? That is probably because the diet which they take. So we don't have enough studies on the pattern of diet taken in Indian patients on gluten-free diet. Probably they'll be taking home food which is free of gluten. But Western studies all show that they actually take a gluten-free, pre-packaged food available from the shelf or from market. So these contains predominantly of refined sugar. So predominantly of refined sugar and fat. So taking that sort of a diet will actually promote the development of fatty liver. Okay. And perhaps the once the disease is diagnosed and once they are put on a gluten-free diet, and many patients that the weight improves and they have some sort of a hyperphagia also. So that gives them a positive feel to continue eating that particular diet, and they probably overeat to a slight extent. So there are multiple factors. It's interesting to note that in the initial part of celiac disease, in fact, there is sort of transaminitis, 30 to 40% of patients. That is believed due to the increased intestinal permeability, endotoxin, etc. And while on treatment, actually that part improves. The increased transaminase part improves, but fatty liver increases. So this disease is actually paradigm shift. From undernourished people, we are seeing well-nourished or overnourished people with features of celiac disease. But I have to make, maybe Govind has to add.
Govind, should we add celiac as a treatment for NAFLD now? Because gluten-free, I mean gluten as a treatment, because all gluten-free patients are doing worse. So do you think there's some other mechanism? Comment from gluten now. May I request the delegates to please, you can put your questions. We have got 5 minutes more. Govind, 1 minute only for you.
So no, half a minute. So the reason is that the gluten-free diet which is available, they are all in high fat. Trans fat, they're all processed. Therefore, they have high trans fat, more fat. That's one reason. Therefore, we ask every celiac to have physical activity in their lifestyle. As you go gluten-free, take care of the diet, number one. Number two, also physical activity. That's the only way forward.
So that means the gluten-free diet is a high risk for development of NAFLD in future. So they will have to be counseled regarding that possibility.
1 minute.
I am Dr. Ashish Kumar Bhattacharya from Kolkata, physician. There is a live program in Kolkata yesterday night. I have been going through online. There is a program regarding this long continued use of PPI. Most of the cardiologists are using this because they are using anti-clot agent as dual or monotherapy. So they are using for long time, for years. And Professor Avijit Tarubdar, nephrologist, were presenting a program that after long continued use, more than 720 days of PPI, there is precipitation of AIN, acute interstitial nephritis. What is your opinion, sir, Honorable Sir?
Prateek, will you answer? Take it up.
Yeah, I can answer. So acute intestinal nephritis is one of the complications of long-term PPI, which has been reported. So there is a link between that. Having said that, the absolute risk of that is extremely, extremely low. So it is definitely possible to get it, but even after millions and millions in doses of PPIs, the number of patients who end up getting it is less than a very, very small percentage. So it is something that you should keep in mind if somebody you start on PPI and after 3 to 6 months develops that. But again, it's a very low risk outcome.
Okay, BD, your comment, you wanted something.
Not my comment, actually. I wanted to ask. The film have got the 10,000 series. They have got the LCI, LI. They claim that more can predict the incidence of Helicobacter pylori, as well the intestinal. Similarly, X1 scope with the Olympus have they have new near white line, new white line. That more possible the incident as well as the intestinal possible, or AI can take in future or merge AI or the incident.
Yeah, BD, thank you. I mean, many multiple questions. So just to tell you, I mean, at least in the form of a randomized controlled trial, Yamamoto has a paper in the Annals of Internal Medicine using LCI that you specifically mentioned, in which he showed that compared to white light, LCI in the upper GI tract was able to detect more lesions. Now, this was not just metaplasia, but precancerous lesions both in the esophagus and the stomach. H. pylori, I would say probably not. Now, there are some Japanese endoscopists with magnification endoscopy and NBI or BLI can look at the pit patterns and can look at the crest in the mucosa and they can predict a diagnosis, but it's not been well published. And the X1 series also similarly, very little data. So that's what I would say to your question.
Thank you.
AI, I think, will be a whole new different thing that we'll need another meeting, BD, but we'll talk about it later.
Yeah, thank you, Pratik. I think I've got the hint that we have just on time. I'd like to thank you, Pratik, for not only the presentation, but taking up all our questions. And I'd like to thank all our panelists who contributed to this very meaningful discussion. Thank you. With that, we close the session.
Good morning. We move to the next session. At the outset, I'd like to the AIG team, particularly Dr. Reddy and Zydus for meeting. I'll have to introduce Dr. David Finn, who is talking to us about the best abstract on IBD presented in DDW Chicago. So I don't need to introduce Dr. Rubin. He is Joseph B. Karsner Professor of Medicine and Chief Section of Gastroenterology. He is a very active worker on IBD. He has the best-selling book. He is the best-selling editor on IBD. And he is one of the editor of Succinct, which you all read for gastroenterology. He has more than 450 publications in peer-reviewed journal, and he has won numerous awards, including 2020 Chairman Prize for colitis. So Dr. Rubin will present to us the abstract from DDW Chicago on IBD. Dr. Rubin. And the panelists include, we have a very known people who are in the panel. And invite them one after another. Dr. A.V. Sivaprasad, Dr. B. Ramesh Kumar, Dr. Devendra Desai, Dr. Gobind Makharia, Dr. S.P. Misra, and Dr. Vinay Thora. And you all know all these panels. They are very important worker for IBD. They are the resource person.
Yes, Dr. Rubin, we will have the recorded presentation now.
I'm so happy to provide you with an update from DDW 2023 in IBD. And I have customized this presentation for you and my colleagues in India with some feedback from our wonderful discussants and moderating faculty. This is where I work. It's the University of Chicago, and you can see in the background Lake Michigan and the beautiful downtown skyline that some of you have seen when you visited for DDW. I do have some disclosures that are relevant, but the presentation I'm going to share with you is from DDW, and it's really focused on the best of, and I hope you'll find it balanced. I've actually worked to co-direct a Best of DDW program in IBD for 14 years. And I've done this with my good friend Marla Dubinsky. And as you can see summarized on this slide, this year at DDW, which was held in Chicago, we had faculty from around the world who worked together with a group of incredible fellows, most of whom were advanced IBD fellows, to develop the program that I am summarizing for you. It is now going to be rolled out across the world as a number of webinars and in-person meetings. You're one of the very first groups to get to hear what came out of this Best of DDW program in IBD. And of course, I wanted to highlight all the fellows who worked very hard, not just to develop this program, but of course to acknowledge the opportunity for all of them to network with our faculty and with each other. The program is divided into a number of different topics, and obviously I can't cover everything in each of these topics, but as I go through several of the abstracts in different areas, you'll see how this is organized, starting with epidemiology, then through the different types of therapies, into disease activity and monitoring, related outcomes, and then of course population health and a variety of comorbid illnesses. So let's start with epidemiology, natural history, and prevention of IBD. The first two abstracts that I'm going to highlight are related to diet in IBD. And of course, we're interested in whether diet is contributing to the rise of IBD around the world. There are two studies that the group chose as being best of in the IBD space. The first one on the left is from the University of Miami, and Oriana Damas and her colleagues specifically looked at Hispanic individuals and using a validated dietary questionnaire, identified specific types of foods that were associated with lower clinical activity and lower fecal calprotectin. This specifically were starchy vegetables and tropical fruits among the Hispanic patients with IBD, suggesting that certain dietary habits may reduce the likelihood, not just of having symptomatic flares, but also of having objective inflammatory relapse. On the right is a study that came out of Scotland, was presented by Charlie Leese, and you can see here that Charlie and his colleagues looked specifically at meat intake. And although there were small differences in overall meat intake, you can see the graphs at the bottom there. The conclusion was that those who consumed more meat more often had an increased risk of flaring in ulcerative colitis. This was not seen in Crohn's, and I hope you can appreciate on the survival curve there that the distinction between those with higher meat intake and those with lower meat intake was not very significant. Nonetheless, this was of great interest, and there's been an ongoing discussion about whether meat might be associated with more symptoms, and in this particular analysis from Scotland, it suggested that it might in fact be associated with active inflammation as well. Now we'll move on to current and emerging therapies and think a little bit more about all the different treatments available for IBD. This is a table summarizing the available and emerging therapies across many different classes of IBD treatments, from the conventional therapies through the biological therapies, and of course, more recently, the synthetic targeted small molecule therapies. So let's start focusing on the non-biological therapies, and there are a couple abstracts of interest. The first one that I thought was of great interest came from Israel, and a well-described data set there called EPIIRN, and they looked for patients with Crohn's disease between the years 2005 and 2020. They matched different groups, and they looked at those patients who were diagnosed with Crohn's and were on no therapy to those who were diagnosed with Crohn's, and their first-line treatment was 5-ASA. And as you can see on the right, whether you looked at time to biologic, time to surgery, time to steroid dependency, or time to hospitalization, there was no difference between those who received no therapy and those who received 5-ASA. The message, of course, is that 5-ASA in Crohn's does not seem to have a role. And I want to drive home that point and encourage you to avoid using this therapy unless you are absolutely convinced it's actually doing something for your patients. The other point I wanted to spend a moment mentioning is the emergence of the targeted synthetic small molecules and our new possibilities for management. Remember that these are not biological therapies. We can avoid the protein loss and protein pharmacodynamic challenges. We don't have to worry about immunogenicity. They have short half-lives. And in fact, we can even use them without steroids in many cases and think about intermittent treatments and combination treatment strategies. At DDW this year, there were a number of updates in the JAK inhibitor class, and I wanted to remind you that the JAK inhibitors include 4 different Janus kinase enzymes, JAKs 1, 2, and 3, and TYK2. And most recently, there's been an emphasis and interest in selective JAK1 inhibitors. There are a number of other JAKs that are either approved or being studied across multiple different combinations of either selective JAK1 or non-selective JAK1 and 2. You can see at the very bottom of this table, baricitinib received FDA emergency authorization to treat COVID. And you can also appreciate the selective JAK1s at the top of this table, filgotinib, upadacitinib, and another one from China called SHR-0302. This was of particular interest. Upadacitinib actually helped normalize fatigue in both Crohn's and ulcerative colitis. And you can appreciate here that distinction. And of course, fatigue is such a common problem in IBD. It's interesting to see it measured in the clinical trials that we use, and also the importance of recognizing that this therapy may be addressing that, not just in bowel inflammation, but perhaps other systemic inflammatory contributors to fatigue. You can also appreciate a post-hoc analysis of patients with Crohn's disease who had fistulas, and upadacitinib at the dose of 45 milligrams had a substantial improvement of fistula control in 47% of patients at the end of induction with complete resolution of drainage, and 50% reduction if you used a measure of greater than 50% resolution of drainage. So substantial improvement in perianal disease, both in induction, and then you can look on the right and see in maintenance. This suggests that, of course, JAK inhibition may be an effective mechanism of control of fistulizing Crohn's disease. The other targeted small molecules that are being developed and studied are the S1P receptor modulators. These drugs work by preventing egress of activated lymphocytes out of lymph nodes, and there are 2 that are of interest. On the left is ozanimod, an S1P1 and S1P5 receptor modulator, and on the right, etrasimod, S1P1, S1P4, and S1P5. So slight differences between them. So at DDW this year, etrasimod had some additional data presented. These are the data in both the placebo-controlled UC cohort of patients receiving etrasimod or placebo, as well as patients who received open-label etrasimod, looking at overall safety. And I'll just summarize to say that the drug was well tolerated in patients with moderate to severe UC. It had a very acceptable safety profile. In multiple sclerosis, the S1P receptor modulators have been around for a long time, and our neurology colleagues are very comfortable with the safety. And I'll also highlight that unlike the JAK inhibitors, there were no cases of herpes zoster, and overall, this was a very safe treatment. It has been raised whether or not we need to worry about cardiac conduction, and that's because S1P3 affects cardiac conduction. Etrasimod does not target S1P3, neither does ozanimod. Now moving on to the biological therapies, a couple of highlights for you, and this of course is to remind you of what biologics we have in IBD, the anti-integrin therapies, which are lymphocyte trafficking inhibitors. Then we have the IL-23 drugs, both anti-P40, which is ustekinumab, and the anti-P19s, which are risankizumab, mirikizumab, and guselkumab. And then we have, of course, our anti-TNFs, which are well known to you. There are 2 abstracts related to ustekinumab that I want to highlight. On the left, you can see a multi-center observational retrospective study that explored patients who received immediate dose escalation where they got the IV loading of ustekinumab followed by 90 milligrams every 4 weeks, or the standard dosing of IV loading of ustekinumab followed by 90 milligrams every 8 weeks, with the possibility of dose escalation later. They looked at both patient-reported outcomes of rectal bleeding and stool frequency and either the fecal calpro of less than 250 or a CRP less than 5 at week 52. Looking at the bottom there in dark blue, you can see the success rate was actually higher, almost twice as high, in those who got the early escalation of dosing, suggesting that higher doses of Eusta might work best or better in many patients. On the right is a different abstract, a retrospective study of Crohn's patients treated with ustekinumab, where they looked at the patients who had inadequate response, and they explored interval shortening and noted a higher rate of clinical and endoscopic remission. At the University of Chicago, we published this years ago in 500 patients that we treated and found similar results. Another study that we thought was of great interest was this study of vedolizumab, the alpha-4 beta-7 anti-integrin therapy, which was studied in postoperative prevention of Crohn's in 80 patients from multiple sites. You can see in this double-blind, double-dummy randomized phase 3 trial that the patients who received vedolizumab immediately after their surgery had substantially less recurrence than those who received placebo. You can see it summarized on the right. Those are the Root-Geertz scores, and the orange represent those who received vedo, the blue is placebo, and you can certainly appreciate that there were substantially more patients receiving vedo who had Root-Geertz I0 than those who had received placebo, and a substantially less number of patients who received vedo who had an I4 compared to those who received placebo. So overall, very nice data suggesting the benefit of vedo in post-op Crohn's. There was this other study that was presented from Australia that was of great interest related to whether you should use combination therapy with vedolizumab. In this really nicely done study, they looked at patients who were on vedo in combination with the thiopurine and whether the thiopurine could be stopped and what happened. The bottom line was that in patients who were biologic naive before they got to vedolizumab and the combination approach, if you stopped the thiopurine, vedo was sufficient to continue controlling the disease. In patients who had already failed an anti-TNF or other therapies before they got to vedo, if you withdrew the thiopurine, vedo alone was insufficient to keep those patients well, suggesting that the thiopurine added a second mechanism of action in tougher to treat patients. So we had for a long time thought and said that vedo would be a appropriate monotherapy in many patients. But now we've seen certainly in some of our more refractory patients, there might be a value in combo therapy. I think we need to think a little bit more about that. Another study of interest was looking at switching to sub-Q infliximab after starting with IV loading. And this has to do, of course, with the emergence of a sub-Q formulation of infliximab that's given every 2 weeks. And you can appreciate here that the bottom line was that switching was not associated with an increased immunogenicity risk and that it was both safe and effective, suggesting that we can take patients who are stable on IV and switch them to sub-Q without any problems. There was some other data presented at DDW that suggested that sub-Q infliximab every 2 weeks might even be a better treatment option because it results in a higher and more consistent serum concentration of drug. Now moving on to disease activity and monitoring and a couple abstracts to share with you here. There's been an increased interest and emergence around the world in the use of intestinal ultrasound for IBD. I've been working with some colleagues here in the United States to disseminate it and have become involved in the International Bowel Ultrasound Group, which I would encourage all of you to learn more about. In fact, there's going to be a training program in Hyderabad in November to teach ultrasound for those who may be interested, and I would encourage you to learn more about it. The abstract on the left is looking at the accuracy of intestinal ultrasound as it correlates to endoscopic findings in pediatric Crohn's disease. This study from Mount Sinai and Michael Dollinger demonstrated very nicely that the intestinal ultrasound measured bowel wall thickness correlated very well and arguably perhaps even better than what you could see by endoscopy. And on the right, a different abstract, this one presented from the University of Calgary, demonstrates that intestinal ultrasound was able to predict smooth muscle hyperplasia as well as other bowel layer involvements to a high degree of accuracy. So point of care intestinal ultrasound is here to stay. It's something that changes your practice by being able to offer to patients as you're examining them in the clinic. And I think that is something more of us should be learning to use and to know more about. There were a number of abstracts, not surprisingly, on artificial intelligence related to IBD. These are several of the ones that were chosen by the group, starting with the one on the upper left there that used images from the toilet and was able to use artificial intelligence to predict what would be found by the endoscopy based on how the stool looked and whether there was blood in the toilet. Very interesting study. On the bottom left, you can see a passive touchless monitoring device that goes on the wall in your bedroom. And it collects data on how you're sleeping, how you're breathing. It can see how you're walking in the room. And it is able to predict flares and remission compared to standard measures to do so. And on the right, you can see a couple other abstracts. One is related to artificial intelligence interpretation of endoscopic images and how it's able to predict the score comparable to the SES-CD. And on the lower right, you can see the computer vision quantification predicting steroid-free remission in the Unify data, comparing the patients who had scopes and using the artificial intelligence interpretation to central reading. So you can see that this is certainly arriving, and how it is going to transform clinical practice as well as clinical trials remains to be seen. Now, moving on to disease-related outcomes, including a variety of other interesting outcomes, I have a couple to share with you. First is the ongoing question about whether patients with Crohn's should just have surgery rather than be treated with anti-TNF. And this particular study from the Danish registry is similar to the design of the well-described Lyric study previously published. In this particular registry, they looked at those patients who had ileocecal resection or those who received anti-TNF between 1 month to 1 year after they were initially diagnosed. And what you can see on the bottom left there in the survival curve, the patients who had the ileocecal resection in red were less likely to have worse outcomes than those who received anti-TNF. The conclusion here was that early surgery may be a more effective strategy, not to mention it may be more cost-effective for many patients with Crohn's, and we need to reevaluate whether that might be the right thing to do, especially in patients who have a long lag time between symptom onset and the ultimate diagnosis of their Crohn's disease. There were a number of new studies looking at large databases and cancer risk in IBD. In this particular summary from the Alberta population-based case control study, Alberta is a province in Canada. You can see some of the results there on the right. Bottom line is that it was younger cancers in patients with IBD compared to the non-IBD population, and that there were a variety of cancers that stood out and were rising, including biliary and liver cancers, as well as the usual cancers of the GI tract and a number of hematological cancers that stood out as well. It's a very interesting finding. Obviously, it's of importance to us. And the problem has been that the cancers that we usually look at in our screening, and so we need to be thoughtful about this. We also need to understand a bit more about why some of these cancers are rising in our population. There's also some additional work to look again at whether biologics are associated with cancer compared with immunomodulators. And in this particular number of abstracts, they were looking at a variety of different data sets. And the bottom line here was that there's increased risk for certain cancers related primarily to thiopurines and the immunomodulators rather than the biological therapy. This is not necessarily novel, but the data continue to show safety of our targeted biologic therapies and some cancers, especially hematologic cancers associated with the immunomodulators. Now moving on to population health, there's been a number of studies now looking at cardiovascular and even neurologic complications associated with IBD. In this particular case control study from the National Healthcare Registry of Sweden, they found that there was an increased risk of ischemic stroke among people with IBD. The highest absolute risk was in those who have an elderly onset IBD, and the highest relative risk were in women and younger onset IBD. In the elderly onset IBD, the risk may be because they were walking around with IBD for a long time before they finally got diagnosed. It may also just be that they're older and then they have the inflammation from IBD. But these data suggest that we should be assessing our patients and aware of the potential that they have a higher risk for stroke, and that certainly patients with chronic active inflammation or more severe disease should be screened or considered for this as a possible risk. There's also ongoing and emerging data to show that patients with IBD have an increased risk of cardiovascular disease. You can certainly appreciate from this population-based multi-center cohort study, looking at some huge data sets, you can appreciate that there was a higher risk of cardiovascular diseases compared to the non-IBD patients, even when matched across age and other risk factors. And it suggests that we should start thinking about whether our IBD population might benefit from cardiovascular screening and whether that should be a common approach to managing our patients as they get older. Also of interest is this ongoing discussion about the overlap between irritable bowel syndrome in patients with IBD. For many years, we've said that up to 50% of patients with IBD will have a functional bowel problem on top of it, and obviously that can confuse our management and interpretation of response to therapies. This interesting study from a single tertiary center in which patients with IBD were having colonoscopies used the specific criteria from the Rome-4 functional bowel diagnoses of abdominal pain. And what they found was that in the patients with IBD who were in endoscopic remission, the prevalence of IBS as defined by Rome-4 was actually low, suggesting that we should be reevaluating the possibility that patients who are actually in deep remission are less likely to have those functional overlapping symptoms. So in summary, I've covered quite a bit in the best of DDW and IBD, and I hope that you found it helpful. Among our older therapies, I presented some data that show that 5-ASA just doesn't work in Crohn's, or is at least no better than nothing. Ustekinumab dose escalation early may have some benefit. Surgery early in Crohn's is effective and may be better than anti-TNF. Vedolizumab can prevent post-op recurrence in Crohn's. Combination therapy of Vedo with ethiopirin might be better than Vedo alone in patients who've been on other biologics before they get to it. And among the new therapies, upadacitinib, that selective JAK1 inhibitor, treats fatigue very well and seems to work extremely well in perianal disease. And the S1P receptor modulator etrasimod looks to be quite safe and is going to continue its development program in ulcerative colitis. We also are reminded that IBD patients have an increased risk of stroke and cardiovascular disease, and that intestinal ultrasound is a technology that is offering quite a large amount of information and is emerging and should be something to think about. Remember that conference that'll be available in India in November of this year. And the artificial intelligence is certainly coming to IBD in a variety of different flavors. I really appreciate the opportunity to present to you, and I hope that you've enjoyed it, and I'll look forward to the questions and discussion.
Thank you, Professor Rubin. It was a wonderful presentation. Are you able to hear us?
I can hear you fine. How is everybody?
Wonderful. Thank you so much, and your wonderful selection of papers. We have a fantastic panel here with Shiva Prasad. He's from Devendra Desai, Mumbai, myself, Matt, Vinay Thorat, Pune, Ramesh Kumar from Govind Makaria from Delhi, SP. So, we have selected the topics in a very good group and selected on this what we have, that we will take up certain areas on diet by ASA. So Professor Makaria, you know that diet is a very important diet is as a causation as for a player as well. So please let us know your diet comes on the relation. Especially we know that there is a debate in South versus North. Or haven't.
Thank you, Dr. Matthew, and Dr. Rubin, the wonderful abstracts. I think every patient with IBD asks us, what do I eat? The khaunkia. That's a very important question. While drugs are homogeneous, efficacy is homogeneous, diet varies in different regions. As you said, that North versus South diet are different. And in globally, diet is different. So the couple of things to practice that what could be the diet which could be prescribed to patients with IBD. And one thing is certain, that increasing vegetables and increasing fresh fruit have been shown in almost all studies, they are good for IBD. Why diet will change IBD activity? All because of changing microbiome. And that's very important. And also we know that fatty food and processed food will change microbiome on one side, but also they have tendency toward increasing weight. And that will have a certain negative effects. So putting them all together, all the studies and two papers presented today, that the patient with IBD should have more vegetables, more fresh fruits. What should they avoid? They should avoid excessive processed food, meat, especially red meat. Third, they should avoid dairy, but they can take yogurt, but they doubt about the controversial about milk, but certainly yogurt they must take. In addition, what should they avoid would be that grains, and it is said that gluten-free may be good for IBD, but there's no data to confirm that. So,
thank you, Govind.
And one more point I want to highlight, taking this stage, that we always think that the North and South, I think this is a premature or immature to think that this disease is common in South, this is common in North. It's just a context. Today we see more in South, but tomorrow you see in North. We also know about the pancreatitis in Kerala and now all over India and all over the globe. The IBD, only amoebic colitis earlier, now we had more TB, then IBD, UC, Crohn's. I think whole country is uniform, and we shouldn't believe in this. That's more common in South, more common or less common in North.
Thank you, Professor Govind. And Dr. Robin, I just want to ask you, chicken meat versus red meat, do you think there is any difference or maintenance of elimination of?
It's a good question. If you look at surveys of patients with IBD, you find consistently that they identify red meat as being associated with more symptoms and problems. Now, on the one hand, it may not make much difference to us thinking about it, but red meat does contain more linoleic acid, and linoleic acid has been associated with an increased risk of ulcerative colitis, and there may be something very distinct and different about it. In general, when we recommend the Mediterranean style diet, which also is unproven but seems healthier, that includes more fish and chicken or even just vegetables rather than red meat. So there's been certainly enough to suggest that we should use less red meat or even avoid it, but we don't have strong evidence. The one abstract I presented to you from Scotland lumped all meat, including fish, together. And therefore, it's a little hard to distinguish from that particular study.
The reason I asked you the same question, Shiva, want to make a quick comment?
Yeah, I just wanted to have raise a query about the first paper about the complex starchy foods that were specific to the Hispanic population. They are basically yuca and tapioca that was described in the study. Can we extrapolate from there what kind of starchy foods in other cultures would be equivalent? Because normally high carb diets, we would like to restrict in patients with any inflammatory. But here we have a little counter argument that starchy foods, in this kind of starchy foods, actually help them. So what would be the likely explanation for those starchy foods actually providing a benefit, and how do we extrapolate it to other diets?
Well, if you're asking me, I'll tell you that I think part of the difference may in fact be related to sugar content and the breakdown of whether that's more high fiber starchy foods like what you just listed, or whether it actually ends up being starchy foods that have more carbohydrates with sugars. But I actually don't know the answer to that. And obviously, the unique part about the study from Miami that you just quoted was also that it was in a specific population of individuals. So you've got potentially the genotype and the diet that together may be contributing, but I don't know the answer otherwise. I'd be interested in your thoughts.
Okay, thank you, Ruben. I think we'll take it in the last session time. Regarding Dr. Vinay Thorat, regarding 5-ASA, it's a very commonly used drug, beneficial also. When you are using, and now the data is any in India.
We have not been using it in Crohn's, except in very, very mild Crohn's disease. We sometimes use it. Goes between 150 to 220. No lump, no complications, minimal pain, but there is no proof. The evidence is very weak. Let me tell you, if you you may act personally, I don't use it, but very occasionally you give budesonide and they start puffing up in the faces, despite whichever preparation you use. Then we are forced to go back on this drug, so the data is weak. The another area where we use it sometimes is in to prevent post-operative recurrence. There again, if thiopurine, any other like Vido and all is expensive. We do agree that's a good drug, but the data is very weak. And unless we have a trial which shows it is eminently useless, that is the same drug we continue to use.
Can I ask you a question? Mild Crohn's disease, only for using.
No, we use the locally acting steroid first. That is the colonic release. We go back to this only if there is a problem with, or we cannot use budesonide. Then we go back because the data for its use is very weak.
Any other patient who has Crohn's disease?
Talazopirin is used in patients with arthritis, and that is well accepted because when there is but how much that helps the colonic disease, we are not sure.
Yeah. So the message is very clear at IASA. No role. We have no time for now. We will come to later. So when coming to the newer therapies, we know that there are empty number of drugs coming in, and we look at the approval of drugs among the years. There are a lot of questions. Let me ask a lot of new drugs coming in. Devendra Desai, what are the new molecules and what is the basic difference? Small molecules. Just tell small molecules.
So Professor David Rubin's slide already showed that. I will just duplicate it, that the small molecules, actually all 5-ASA azathioprine are small molecules. So we are talking about new oral small molecules who have the weight of less than 1 kilodalton. And these, because they are small, they can diffuse into the cell as compared to larger biologic molecule which remain in the vessels and extravascular space. And the most important thing about these small molecules is that they can be given orally and they have no immunogenicity.
So coming to the study part, fairly small molecules. What is your thought about possibly algorithm? Where do you piece? And do you think the future biologics in?
So it is actually already replaced in moderate to severe ulcerative colitis. So basically, if we go by the guidelines, ACG and ECHO have already suggested that tofacitinib can be a first-line molecule in patients who have moderate to severe ulcerative colitis. And we have now Indian data, which hopefully will be published soon. So we have definitely it will partially replace the biologics. That is one thing very sure. Whether it is 30% or 80%, we will know from the data. What I wanted to ask you is, now we are actually seeing failures to TOFA, and I would like to ask Professor Rubin as to now, once there is a failure to TOFA, do we go back to our original algorithm, or do we wait for wait for upadacitinib or so? What is your practice?
At the University of Chicago, we've treated 250 people with upadacitinib and 400 people with tofacitinib. And we actually had an abstract at DDW that I didn't show you that looked at our first 20 patients who were on tofacitinib and didn't respond or lost response. And 18 of the 20 responded to upadacitinib. There was also another abstract from a different group with a smaller number showing a similar finding. So I definitely think that all JAK inhibitors are not the same. It may be that TOFA, because it's a pan-JAK inhibitor, and upadacitinib, because it's a selective JAK1, that there's a difference in mechanism. It may also be as simple as just differences in dosing. But either way, you can definitely think about upadacitinib after TOFA doesn't work. And in answer to the other part of your question, of course, you can go from tofacitinib to a biological therapy. That's absolutely possible.
Dr. Devendra, is coming down in a big way, and the promise is quite good. Do you think that more
So we have seen in the last year DDW abstract and this year DDW abstract that upadacitinib is useful in luminal Crohn's disease, and it can have endoscopic as well as clinical remission. Now, this year's DDW abstract have shown that it is useful for perianal Crohn's disease. So taken all the information together, along with no new safety concerns except for probably herpes zoster in few patients, it is a safe drug and it is useful in Crohn's disease. And previously, these patients who have received upadacitinib have been failure to more than one biologic. So yes, definitely, it will have its own role in future.
Thank you. I think a small question to Professor Rubin. You have just casually mentioned about that. Why TOFA is not effective in Crohn's? Or it is a pan drug, non-selective, but UPA is highly effective. Can you just please tell us what's the reason?
Yes, I think it's a very good question. I'll remind the audience that there were 2 phase 2 trials of tofacitinib in Crohn's disease. Both trials were negative. And if you look at those trials, there were a couple of differences in the design. One was that they did not require endoscopic activity on entry. So you had a less rigid inclusion criterion, and therefore you may have had patients who had no active disease at the time they entered, and that resulted in higher than expected placebo rate responses. But the other possibility, as you've already alluded, is that upadacitinib, either by a difference in mechanism or a difference in dosing schedule, or even in the outcome, the upadacitinib induction trial in Crohn's was 12 weeks long. Whatever it may be, clearly it has a very strong response in Crohn's disease. There's no doubt about it. It hit every one of its primary and secondary endpoints. So there's clearly a role for that. And when we did some work with tofacitinib in the real world, there was a group of US centers, including ours, that combined their data. And we did show that tofacitinib in Crohn's disease could work if you looked at just colonic disease. So there was some role for it in some patients, but there's no doubt that there's a very strong difference with the upadacitinib. And whether that's because of study design or really a mechanism and dose issue, we don't fully know.
Thank you, Professor Ruben. I think we'll move on to the infliximab biologics. Dr. Shiva, what's the problem with infliximab? Are we facing any issues in India? And do you think that going to or found to be more cancer use in India?
Yeah, thank you. I'm a strong advocate of subcutaneous delivery of any of these drugs for IBD because there's a big mental block for the patients to get a periodic intravenous infusion. And many smaller centers, smaller hospitals where the patients may be living close by, they often refuse to give these infusions for fear of reactions. And the patient again has to travel to the parent center. So in my own practice, by default, adalimumab, which is has always been my preference for purely these practical reasons. Briefly about subcutaneous infliximab, just like to about it is the manufacturer CT is the European biosimilar, that is Remsima or CTP13, which is the only biosimilar approved by EMA for as a biosimilar to infliximab, and they had come up with this subcutaneous formulation. So there's only one manufacturer, not Remicade. This is from the biosimilar that is available in Europe. So as far as that is concerned, definitely there's a great help as far as the patients is concerned. My query to Dr. Rubin is, if you're already using adalimumab as a primary subcutaneous anti-TNF in anyone's practice, is there a reason? Is there a clinical situation where you would say subcutaneous infliximab would probably give it some benefit over adalimumab?
Yeah, that's a great question, and I don't think we know the answer. I'll tell you that in the United States, we do not yet have sub-Q infliximab. I will tell you that the pharmacokinetics of sub-Q infliximab given every 2 weeks actually looks like it might work better than what we've been seeing with IV infliximab, just from the standpoint of the serum concentrations and the pharmacokinetics of it, because you're getting it more frequently, you have a more consistent level. Whether it's actually going to be better than adalimumab is not known. And I think it's an excellent question, because in my practice, if I start with adalimumab and the patient doesn't have a preferred response or doesn't get into remission, I think IV infliximab is still a good option because it's IV and it's weight-based. When you talk about sub-Q, the only difference with the infliximab, remember, sub-Q infliximab has an IV loading phase. So will it be different because you'll give the IV just to get the loading doses in, if you can and if your patients will let you, and then the injections will be for maintenance? That might be the reason it's better than adalimumab, but I think we have to do that work to figure it out.
Thank you, Professor Ruben. I think we'll come to the next. Any quick comments from the audience? You can actually show your hand. And this is regarding industrial ultrasound. So, Ramesh Kumar, what's your opinion about it? Do you think industrial ultrasound is going to be, and this is India? Will you place this IUS in India?
Very good question. Actually, see, intestinal ultrasound is very good modality as far as pediatric population is concerned. When we are strongly suspecting this IBD, you do the scan, bowel wall thickening of more than 3 millimeters, especially in the sigmoid colon. Of course, it varies from sigmoid colon to transverse colon and descending colon, ascending colon. But basically, in patients,
basically, it is the increase in thickness of.
Definitely has got role.
What else? What else?
Other than that, vascularization it will tell you. Then fistulas it will tell you. Abscess also will be taken care by ultrasound. And at the same time, I think you can, if really required, you can give the treatment then and there.
Picture also shows the fat around the bowel also.
Yeah.
Can I ask one question to Professor Rubin? Is there any guideline whether gastroenterologist is better or radiologist is better in doing intestinal ultrasound? Because they have been doing it for years and now we have to learn all over again.
It's a very common question, and it is a little bit of a political question. But I will tell you that the reality is that once you learn intestinal ultrasound, and you know how to look at those parameters, and those were very nice images, by the way. The reliability between intestinal ultrasound performing by gastroenterologists is as good or better than MRI by radiologists. So don't be shy about it. It is a very easy test to learn. It just requires experience and some volume to be able to do it. But I'll tell you that once you know how to put a probe on somebody's abdomen and see the bowel wall thickness and measure it, you'll realize how much that can change your practice right there. I mentioned briefly in my recording that there's going to be a training course for this in Hyderabad in November, and I'm hopeful I'll be there. And some of the other experts in ultrasound are coming, and I'm hopeful to see some of you there in person because it's a wonderful tool. So I'm obviously a bit biased, but I did discuss with my radiologists, and there are studies to show very nicely how reliable this measure is.
The other
I
point
think-
is CT is a lot of radiation. MR is so in that situation, ultrasound is definitely plays a major role.
The question is that
Well,
whether
I'll add two more things if I may, sorry. I would also add that it shortens your time to decision making because you get to see it right there on the spot. And it literally changes what I will do for a patient based on what I see in the clinic. I don't scan everybody, but there are definitely people in whom I do it right when they're in clinic seeing me. The other point I'll make is that there's nothing better than having a patient see their bowel and understand a little bit more about what we're trying to do, and they see it in real time. So that's also a benefit of this particular test.
Thank you, Professor Rowan. I think the other imaging modalities are not going to be away. We still need it because for the initial diagnosis.
Of course.
But for point of care and for repetitions, etc., I think this is going to be a good one. Dr. S.P. Mishra, what is your comment on picture on intra? Do you think this can?
Yes, it's very useful. And one thing which is very common is after stricture, you see a bright area, a hyperechoic area. It's not just like a stone and there's no acoustic shadowing, but you see a hyperechoic area. And then stricture dilatation can also be seen in these patients. It's very easy in pediatric practice, a bit difficult in adults, but if you are used to it, you can pick up strictures too.
I agree. There is actually stricture can be due to inflammation. There is fibrosis to actually proximal dilatation.
Even in fibrosis, there are two types of collagen. Type 1 collagen is reversible, type 4 is not.
Yes, thank you. I think we keep on moving. Dr. Devendra Desai, the biologics. We have plenty of biologics. Also, we have now modulators, especially thioprim, study has been done and absolutely presented. What's your comment in this, and how do you choose your biologics for your patients?
First, I will address the second question. How do we choose biologics?
Very brief, only 2 minutes.
Yes. Okay. So for ulcerative colitis, we know that for acute severe ulcerative colitis, where we want the action fast, we have infliximab and now tofacitinib. In patients who have moderate to severe, we know that all the biologics will be equal. And when selecting these, we consider the age, previous, whether patient has previous malignancy or no. So in this patient who has previous tuberculosis, so if any of these are there, we would go for either vedolizumab or ustekinumab. And coming to Crohn's disease, we know for stricturing disease, the data is only, more data is for adalimumab. And for other conditions like luminal, all the biologics are equal. For perianal Crohn's disease, we know that we have infliximab with combination of short-term antibiotics. And now we have some data about upadacitinib. So as far as the combination is concerned, now we know that for infliximab, combination with azathioprine is additive, not so for adalimumab, but it can prevent antigenicity. And now we know that vedolizumab, it may be having some benefit to combine.
Thank you. Initially, we thought that in combination of infliximab, the immune system cannot therapeutic benefit. And many times combination is not being recommended or immunogenicity. But in vedolizumab and other type of work, but here it is found that combination of vedolizumab and heparin is found to be therapeutic. Professor Rubin, can you just
Azathioprine in combination with the biologics, is that what the question is?
the question is a combination of vedolizumab and azathioprine. Because here there is no benefit on immunogenicity, but here is we have found that the efficacy is better.
I hear you.
I just correlating to that, in your study, the study they had mentioned that it only works in biologic exposed and not the biologic naive. So would that still be a consideration as far, I mean, because the patient has been exposed, is the immunogenicity then factor come into play?
Right. So in general, we have said that you do not need a combination thiopurine with vedolizumab or ustekinumab. And for that matter, you won't need it with risankizumab either, for the purposes of enhancing the serum concentrations of the drug or preventing immunogenicity. And that remains true. In the study from Australia that I presented and was nicely summarized just now, it is true that they found that in people on combination vedolizumab with azathioprine, all of whom had 6-thioguanine levels over 300, by the way, so optimized thiopurine. When they removed the thiopurine, to their surprise, they found that in biologic exposed patients, so people who had been on TNF prior to vedolizumab, they actually had a higher relapse rate than those who were bio-naive and vedolizumab was their only drug. And then when they took the thiopurine off, they were fine. So I think that what that shows is probably that the azathioprine is treating the disease as a second mechanism, not making the vedolizumab work better. But it's a really important question because obviously one of the benefits of vedolizumab that we've enjoyed is its safety. So if we're adding a thiopurine now to some of these patients, even if we think that they need it, we have to keep in mind that that changes the safety profile. So I still use vedolizumab as a first-line drug if it's my first biologic in a patient with colitis. If it's the second biologic, I still try to use it first line. I mean, I still try to use it as monotherapy, but I will tell you that if they don't respond to the monotherapy of vedolizumab after an anti-TNF, I go right to a JAK inhibitor. And that's probably the way we should think about some of these in terms of sequencing.
Thank you. Any quick audience?
Thank you for your question. The reports you're talking about that I know of came from San Diego in the United States, and subsequently larger series did not replicate those findings. And as I mentioned, one of the abstracts from DDW looked at vedolizumab, started immediately after surgery for Crohn's disease, and there were no wound healing problems. So I think that that's probably been looked at carefully now and reassuring, and I wouldn't worry about delaying starting the therapy or even having a washout before surgery.
Very brief, please.
Hidradenitis a report have a patient there be an
Yeah, so hidradenitis, I think, is underdiagnosed, sometimes confuses our interpretation of perianal disease. High-dose anti-TNF works, and I agree, I think JAK inhibitors work well. In the patient that you described with Crohn's disease, it would depend in my mind on where the Crohn's is located, because I would still prefer to give high-dose anti-TNF, but giving tofa in that scenario would be okay. Just remember that you can't combine tofacitinib with other drugs. So if you're going to use TOFA for her hidradenitis, you have to stop whatever else she's on right now. The answer, of course, will be when it's available, upadacitinib, because that will treat her Crohn's and her hidradenitis. And I have several patients who have hidradenitis in Crohn's who are on upadacitinib already.
The question, gastroenterologist versus radiologist doing intestinal ultrasound, I just have a comment that once we were being trained at All India Institute 40 years back, our professor B.N. Tandon, we had 4 ultrasound machines in the department itself. And he encouraged the residents to do the ultrasound because he felt that they were in a better position to interpret the ultrasound because they knew the clinical profile rather than the radiology.
I think, in many places in India, even abroad, gastroenterologists, they do the ultrasound. Radiologists, of course, doing. And for ultrasound, if gastroenterologists are in the outpatient ultrasound, ever since I passed my. Rubin, you want to make any comment?
I would just say that there was a time when radiologists would take a history and think like clinicians and then do the exam.
Excellent.
And with all due respect to our radiology colleagues, it's become a technical specialty in a dark room. And I think that that's a problem. So I 100% agree that there's nothing better than to understand the patient's symptoms and to look with any of our procedures in GI. That's why it's fun to be a gastroenterologist.
Good. Partha, very quick comment.
So multiple inter-observer studies has been done and which has shown that the agreement is almost 0.88 between the radiologist and gastroenterologist. I wanted to ask another question actually regarding the irritable bowel syndrome symptoms in diabetes.
We are actually,
Yeah,
you can ask later. So,
That's all right. Martha spent a lot of time with me. He knows he can ask whatever.
I think, we are that AI is taking out many clinical decisions. And I would just, Vinay, the computer man that's into him. But he has a person who was in a tiger, no?
Yeah, I did that. But
Okay. The limitations and advantages in the role.
Thank you. I did see that very interesting image of the stool and being used for artificial intelligence. So it has moved from the software offices to the toilet seat, and I pray that it doesn't move any further than that. But anyway, jokes apart, I think AI is now already it is there for scoring and grading the disease. And this is very important because it will bring uniformity to reporting. It will help the studies which are being done. Plus, very mild disease which can be missed by someone who is new. They may be encouraged to take biopsies and make a diagnosis of very mild disease. Secondly, adenoma pickup and dysplasia imaging. AI might also help, sometimes superior in some studies to human eye, especially when you're exhausted towards the end of your endoscopy session. Apart from endoscopy, there are other areas where AI will help, probably in imaging. You're doing an MR in a patient with Crohn's, might pick up some subtle changes with the eye may not see, stricture or enhancement of the wall. Or similarly in histopathology, might pick up some changes which dysplasia are still not on the block, but soon that's going to come. So these are the areas very exciting, and I'm sure in the years to come, we'll have more of that.
No, not many answers now, but I think there are more questions. And Professor Rubin, any comment on AI in making a diagnosis? Do you think the AI is good for beginners or for the experts?
It's an interesting question. In terms of making diagnosis, where I think AI might help clinicians is in primary care, where it'll pick up subtle changes in blood count, or it'll analyze the symptoms and the labs and tell the doctor that they should be thinking it might be IBD earlier. Because as you all know, people get diagnosed with IBD usually after they've had symptoms and even seen doctors for years. So I think that's where it'll have a role. I don't know otherwise if we'll get there in the diagnostic tests quite yet for diagnosis. Where I think it clearly has a role is to improve our ability to monitor the disease.
I think
Okay,
there is
Partha.
one paper on AI in this intestinal ultrasound, which is also published, which has shown for novice gastroenterologists that may help to detect the bowel wall thickness.
No,
Yeah.
bowel wall thickness can be due to many reasons.
Yeah,
you
yeah,
know. I
but
think that
for
that
novice
cannot be.
novice gastroenterologists,
Industrial ultrasound is valuable when you know a patient and you are following up. For making a primary diagnosis.
in known cases of IBD,
Yeah,
they
yeah,
compare.
agreed. So I think we'll move on to the next area. It's very interesting area, very relevant for India. Shiva, what do you think? Ileocecal resection related.
Yeah.
We are given a chance. Treat him first and fails you take a for surgery.
Yeah, this is a very interesting paper, and as Dr. Rubin mentioned, also ties in with the previous lyric data. But there are two differences between there's a main difference between the lyric study and this one is that the lyric actually had patients who had failed biologics and immunomodulators and were being considered for failed steroids and immunomodulators considered for biologics. At that point, would you like to do a surgery? And if the disease extent was less than 40 centimeters, then would you like to do a resection or go for biologic? Surgery had an excellent role to play in that scenario. Actually, has been happening for long. In this study, it is slightly different in the sense like they're looking at that is newly diagnosed patients with CD, and then what is it that your options that you're giving? Are you going to treat them with surgery or you're going or with biologics? The question here comes is the patients who underwent surgery were just given an induction course of steroids, and then they were the terminal ileum was resected. But in a patient, but my question to you, Dr. Rubin, is if you have a patient who is newly diagnosed, first presentation, and your hand has responded to steroids, according to guidelines, this is the one scenario where they're really not required to go on to maintenance. You can observe them if it has been their first presentation, isolated terminal ileal disease,
Shiva, very
responding to
brief,
steroids. Sorry?
No time.
So what, in that situation, is it required that you have to consider for step-up treatment or you can just observe?
In my practice and in my recommendation to you is it depends on the way the patient presented and specifically their age. If it's somebody who presents with their first obstructive episode or they're newly diagnosed and they're over age 50, I would suggest to you that one possibility is they've had mild, slowly progressive disease for many years, and therefore a watchful approach to their follow-up after one course of steroids is completely appropriate. If they presented obstructed, obviously, it's a little different because you're going to want to take control. But in that scenario, I think surgery is fine, and then actually doing no therapy after surgery with monitoring is appropriate. In the young patient with new Crohn's, I think you have to be very careful about what approach you're going to take. But I don't disagree that you can hold off therapy after the first course of steroids as long as you monitor the patient carefully. It's not that you send them on their way and tell them to come back if they have problems. I think you have to figure out how can I best keep track of what's going on. Maybe it's 6 months, maybe it's even a year, but you need to have a plan. That's another role for intestinal ultrasound, but frankly, in my practice, it might be CRP, it might be calprotectin, but I don't let those patients disappear. I make sure they have a plan for follow-up. So I agree, going right to a biologic or to surgery may not be the right approach for many patients. And I think that we spend too much time talking about advanced therapies when there are lots of people who have non-progressive Crohn's.
Thank you. We'll move on to Govind Makharia. There are a couple of papers on malignancy in IBD in the present abstract. And what do you think? Real problem in India or the main issue? On that?
A couple of points to make because the time will not permit us to go on detail. First, what is my risk of having cancer? There are no data from India. I'm talking overall. But look at data from US, as longevity increases, every second person will develop some cancer, and every fifth person will die of cancer. So this is the general population. IBD will increase the risk of malignancy by 12%. Point two. Point three, which patient with IBD will have what cancer? They can have cancer of any kind, mostly large intestinal cancer, colorectal cancer, and this also risk of colorectal cancer also will be influenced by family history, and if they have other pre-malignant conditions like especially diet, like those who have a red meat as a main diet will also enhance the risk of malignancy in them. They can have a small intestinal cancer, they can have lymphomas, they can have a hepatobiliary cancer, which is very common, like PSC, IBD PSC cancer. It's very, very common. Question is, what in Asia, the risk of cancer is almost equal to rest of the world. We should not believe that our IBD patients do not have cancer, but this is a misnomer, and we should start screening these patients. And last point, what do I do to decrease this cancer? Now there's a data that if you control the most important driver which leads to cancer is disease activity. So overall, you will like to think that how can they control the disease activity over a long period of time? That's one therapy which can decrease the risk of cancer. Although the data has appeared now that those patients who have better activity have a less cancer risk.
Thank you, Govind. I think we have no time for discussing further on that. I think the message is very clear. You can have intestinal and extra-intestinal malignancy in IBD, and it is almost similar to other parts of the world. I think we're looking. So cardiovascular disease is actually a new entity which is coming into IBD. Similarly, that we see in NAFLD coming in IBD. So, Dr. H.P. Mishra, a quick comment on cardiac and stroke events of IBD, and critically just look at the paper what you have presented there. Your comment, sir.
Yes, every inflammatory disease like IBD has effects on the heart as well as in the brain. That's because of the inflammation, and the cardiomyocytes are reprogrammed and there's remodeling. They lead to more myocardial infarction, heart failure, even tachy and bradycardias, as well as conduction defects. So I think the second problem is their age is also, on the higher side. So they are prone to develop these things. But as a control, if you take a control, it's more higher in patients with IBD, and it's high time that we start looking for all these things and take prevention for it.
What I noticed that it's actually very difficult to differentiate between two groups. How is the control group being analyzed?
Control is non-IBD.
I agree that, because the disease population has got multiple comorbid factors,
Yes.
the confounding factors. You don't know, but I'm sure.
But multivariate analysis will take care of that.
IBD and IBS, Dr. Ramesh. Does it exist, combination to identify clinical practice?
Definitely it exists. We have approximately 22 patients. And especially these people are restless patients. So those set of patients, but this patient requires to give a lot of patients, and that followed by you have different setups like IBS, IBD, active, inactive. Again, their surveillance data is there. You need to go into that detail.
Thank you. And Professor Rubin, do we have to treat patients with IBD for IBS at any time? Or you think just control IBD, their IBS symptoms also disappear?
No, clearly there's a lot of reasons we diagnose people with functional overlap. You just want to make sure you understand that they're not inflamed. But after you do that, of course, they're going to have some problems. I think that the older data on functional bowel with IBD was confounded by the fact that we didn't look for deep remission. But there's still not only patients who are going to have some type of neurogenic IBS type problems, but also a variety of anatomic problems. We've learned, for example, even in ulcerative colitis, that there is fibrosis in the submucosa and therefore diminished compliance of the bowel. Well, that could easily be interpreted as constipation or urgency when there's no inflammation that we can see. So I think it's more complicated than that. We just have to rely on our tools to know whether we have the disease under control, and then we can focus on using the other therapies. I have many patients in my practice who are on irritable bowel symptom management and prescription therapies on top of their IBD therapies.
Thank you, Professor Ruin. We had a wonderful session. We had fantastic panelists and audience participants. Dr. Partha, last question.
Just a comment that few studies have seen that patients who have already have mucosal healing, that if you do a confocal laser microscope, find some barrier function dysfunction, that may explain their IBS symptoms and may not be having. What's your thought on that?
Yeah, I think what you're referring to, Partha, is molecular healing. And we're starting to understand that the closer you look, the deeper you go, the more we learn. And there are some techniques now that show that you can predict relapse if you look at a molecular level. Just not sure yet how to incorporate that into everything else we do. But obviously, it's very cutting edge.
Thank you, Professor Rubin. It was a wonderful selection of IBD abstracts, and we learned a lot, and we could generate a lot of discussion. Thanks for the fantastic panelists who actually did the job. I was only a referee. I was just running behind the great players of IBD. I was just running behind. Thank you so much for thanks AIG for this opportunity. Zydus also for this opportunity.
Thank you.
Very much, man. Before we go for tea break, just an announcement extension of what David was telling us. November, we're having this ultrasound, which is trying to take gastroenterologists back in ultrasound point of care. IBD clinics, for last few months, we have been practicing AIG with a phenomenal difference in how we practice medicine, how I think shift from radiologist to gastroenterology, at least for specialty. We're going to have Christian Masters from Europe, David Rubin, many other international experts coming for this. The problem with this is delegates are going to be chosen. You can't just register and walk in. So if you want to, you have to do it early. Delegates are chosen from all over the world, and they only select few will have an opportunity to attend the workshop, which will we'll break for tea and then come back in for the endoscopy session. Pleasure.
Sir, good morning, sir. Can you hear me, sir?
Yeah, I can hear you very well. Yeah.
Sir, are you going to share your presentation, or should we play the recording?
I think you should play the recording. It's probably easier, I would think, and then
Yes,
I'll
sir.
just join after the recording is over.
Okay, okay, sir. Thank you, sir.
Thank you. Yeah.
Or
Welcome back. Now we are starting with our last session, last module of 13th Best of DDW. And it's my pleasure in introducing good friend Dr. Shyam Vardharajulu, who is the president of Digestive Health Institute at Orlando, and and he specializes in treatment of complex pancreatic inability. We all know that he has demonstrated and he has interacted with this audience many a times, and one of the most avid writers. He has more than 300 professional articles and 40 textbooks, and he has been the former editor of endoscopy section for clinical gastroenterology and hepatology, and deputy editor of digestive endoscopy. And welcome Dr. Shyam Vardharajulu. And I have got very eminent panelists. Hello, Shyam.
Randhir, good morning.
Good morning. And I have got very eminent panelists, Dr. Ajay Kumar, Dr. P. Ravi Shankar, E.V. Rao, Dr. Pankaj Dhawan, Rajkumar Wadhwa, Tomil Shah, and Zahir Nabi. And I'll invite all of you to be on the stage and conduct the proceedings here on. Thank you.
Florida. It gives me great pleasure to make this presentation for the Digestive Diseases Week update hosted by the Asian Institute of Gastroenterology. My sincere thanks to Dr. Reddy and his team for this kind invitation. For this section, I have selected approximately 20 abstracts, and they are all based on clinical application, study methodology, and relevance to clinical practice. So we will now start with the ERCP section. The first study is looking at the lack of effect of endoluminal RFA on survival and stent patency in patients with cholangiocarcinoma and pancreatic cancer. These are the results of a randomized trial from the Czech Republic. So endoluminal RFA has been suggested as a promising treatment modality for palliative treatment in patients with cholangiocarcinoma and pancreatic cancer. In this randomized trial, patients undergoing ERCP were randomized to two groups. Either they will undergo endoluminal RFA with stenting or only stenting as treatment for malignant biliary obstruction, with the primary outcome being survival and stent patency. 161 patients with malignant biliary obstruction were randomized to either group. The recruitment was terminated for futility after an interim analysis was conducted. And this was because there was no difference in survival in either patients with cholangiocarcinoma or pancreatic cancer between the two groups. No patient survived more than a year. Furthermore, no benefit was seen in stent patency between patients with cholangiocarcinoma and pancreatic cancer, whether they underwent endoluminal RFA with stenting or stenting alone. So the authors concluded that in malignant biliary obstruction, endoluminal RFA does not add any value because it does not increase patient survival or improve stent patency. The second study looked at pottery settings during ERCP, whether pure cut or endo cut was ideal for performing a biliary sphincterotomy. This was also a multi-center randomized clinical trial. In this study, the authors wanted to evaluate the outcomes between pure cut and endo cut when performing sphincterotomy. So over a 2-year period, consecutive patients with native papilla who underwent biliary sphincterotomy were randomized to two groups. Either they underwent pure cut or they underwent only endo cut for biliary sphincterotomy after cannulation. The primary outcome was post-ERCP pancreatitis, and the secondary outcomes included bleeding, infection, and perforation. 550 patients were randomized between two groups. Overall, the rate of post-ERCP pancreatitis was higher in the endo cut arm. On multivariate analysis, requiring more than 5 attempts at biliary cannulation and using endo cut were more suggestive as risk factors for post-ERCP pancreatitis. Intra-procedural bleeding occurred more often with use of pure cut, and delayed bleeding was more frequent with endo cut. There was no difference in other adverse events. So the authors concluded that endo cut is associated with high rates of post-ERCP pancreatitis and delayed bleeding, whereas pure cut is associated with mild increase in intra-procedural bleeding. Therefore, pure cut was chosen to be the preferred electrophysiology mode when performing biliary sphincterotomy. The next study looks at endoscopic snare papillectomy of ampullary adenomas, and they were evaluating predictors of incomplete resection post-papillectomy pancreatitis. So, to provide a background, the objective of the study is to determine risk factors for incomplete resection of ampullary adenomas following endoscopic snare papillectomy, as well as impact of rectal indomethacin and pancreatic stenting in this patient population. This was a retrospective study performed over 8 years, where logistic regression was identified to see for predictors for residual disease and post-procedure or post-papillectomy pancreatitis. 136 patients with a median adenoma size of 20 millimeter from the study cohort, and about 35% were laterally spreading tumor. Extension of the tumor into the common bile duct was seen in 20% of patients. En-bloc resection was possible in 57% of patients, and the mean follow-up was approximately 30 months. Residual neoplasia was seen in 50%. Factors associated with residual adenoma on follow-up were extension of tumor into the bile duct and piecemeal resection. Eventually, Whipple was required as a salvage procedure in 10% of the study cohort. Post-procedure pancreatitis occurred in 15 patients. Prophylactic pancreatic stenting was performed in 90%, of whom 51% underwent only stent placement, and 49% received a combination of pancreatic stenting and rectal endometrium. Decreased rates of post-ERCP pancreatitis was seen in the pancreatic stenting group and not in other patients. So the authors concluded the residual adenoma is seen in nearly 50% of patients with ampullary adenoma undergoing snare papillectomy. Performing a piecemeal resection and extension of the tumor into the common bile duct are predictive of residual disease. Performing snare papillectomy is associated with a 15% risk of post-papillectomy pancreatitis and is lowered only by pancreatic stent. The last study in this group evaluated pancreatic stone size and density as predictors for ESWL session that is used for successful stone fragmentation. So the objective was to evaluate the role of CT-based assessment of pancreatic duct stone characteristics in determining technical efficacy of extracorporeal shockwave lithotripsy. This is a retrospective evaluation of patients with pancreatic duct stone who underwent ERCP with ESWL for stone fragmentation. Stone fragmentation was defined as breakdown of stones to less than 3 mm. Demographic data, clinical data, Isbicki pain scores before and after fragmentation were all recorded. The authors determined the relationship between pancreatic duct size and density and looked for correlation with the number of ESWL sessions required for successful fragmentation. 187 patients underwent ESWL, and there was significantly strong correlation between pancreatic duct stone density and number of ESWL sessions. A single metric was devised whereby the product of stone size and density was divided by 100, and this product had significant relationship with the number of ESWL sessions. Pancreatic duct stone density metric had an area under the curve of 0.929 in predicting number of ESWL sessions, and a density threshold of 895 ounce-field units could predict the need for multiple ESWL session with accuracy of close to 90%. So in conclusion, pancreatic duct stone size and density measured by a coefficient on CT are strong predictors of technical efficacy of extracorporeal shockwave lithotripsy in terms of determining the number of sessions required for stone fragmenting. So to recap this session, in malignant biliary obstruction, adding endoluminal RFA to biliary stenting does not improve patient survival or stent patency. Pure cut should be the preferred electrocautery mode for biliary sphincterotomy, as endocut is associated with high rates of post-procedure pancreatitis and delayed bleeding. Residual adenoma is seen in nearly 50% of patients after endoscopic snare papillectomy, with common bilate extension and piecemeal resection being predictors of disease recurrence. Pancreatic duct stone size and density on CT can predict the number of sessions required for successful fragmentation of the stones by extracorporeal shockwave lithotripsy. We'll now move to the next session, which is endoscopic ultrasound. The first is a randomized trial comparing direct endoscopic versus step-up transluminal interventions in necrotizing pancreatitis, results of a randomized trial. So the background of this study is to compare outcomes before two treatment approaches, whether you perform endoscopic necrosectomy at the first session or a step-up approach whereby a luminopposing metal stent is placed, followed by necrosectomy as required based on treatment response. In this multi-center study, 70 patients were randomized to either group, and all patients had infected necrotizing pancreatitis by CT imaging or clinical symptoms. The primary outcome of the trial was number of re-interventions performed to achieve treatment success, which was defined as symptom relief in conjunction with the disease resolution on CT scan at 6 months. The mean number of re-interventions required was significantly lower in patients who received necrosectomy at index session as compared to the step-up approach. While overall length of stay was significantly shorter in the direct necrosectomy group, there was no difference in treatment outcomes, adverse events, mortality, and median number of readmissions between both the index session and step-up treatment group. So the conclusion was that direct endoscopic necrosectomy at index treatment compared with step-up approach significantly reduced the number of re-interventions required to achieve treatment success and also decreased length of hospital stay. The next study looked at efficacy and safety of permanent transmural double pigtail plastic stents after resolution of pancreatic fluid collections. This was a systematic review and meta-analysis. So this study compared the efficacy and safety of leaving double pigtail plastic stent versus a standard approach whereby the stents are removed from the pancreatic fluid collection following endoscopic transmural drainage for pancreatic fluid collection. The studies comparing outcomes of permanent double pigtail plastic stent and a standard approach whereby the stents are removed after resolution of pancreatic fluid collection were included. Studies with less than 6-month follow-up or less than 10 patients and those published only as abstracts were excluded. The main outcomes measured after PFC resolution were recurrence of pancreatic fluid collection, number of reinterventions, adverse events, and technical success for placement of double pigtail plastic stent. A total of 16 studies with 1,285 patients were identified. Patients who underwent single session or a standard stent removal at time of PFC resolution had 4.6 times greater odds of developing fluid collection recurrence and 2.8 times greater odds for reintervention. The long-term adverse events included 6% spontaneous migration, 1% perforation, 1%, mostly in patients with indwelling plastic stents. Overall, the technical success of double pigtail plastic stents was 93%, which means in 7% of patients after the stents were removed, the cavity could not be successfully intubated for replacing them with plastic stents. So the authors concluded that permanent transmural double pigtail plastic stents after resolution of pancreatic fluid collection is safe and superior to standard stent removal in reducing the risk of pancreatic fluid collection recurrence or reintervention. The next study looked at quality of EUS-guided liver biopsy and compared them with percutaneous and transjugular methods. In this study, which was retrospective, patients who underwent liver biopsy over 2 years were identified. The extracted data included quality of the liver biopsy and number of portal tracts along with complications. And portal tracts were defined as adequate when more than 11 triads were identified. And these are the results. Of 244 patients either underwent EUS, percutaneous, or transjugular approach. As it can be seen, the quality of biopsy as measured as adequate biopsies, fragmented tissue, presence of more than 11 portal triads, and length of core were all significantly superior for percutaneous and transjugular approaches as compared to EU. There was lower complication rate for the EUS-guided approach. So the authors concluded that EUS-guided liver biopsy does not appear to perform as well as percutaneous or transjugular liver approach. The next study looked at surveillance for presumed branch duct IPMN of the pancreas, looking at stability, size, and age, and determining targets for discontinuation of surveillance. So the background of the study is that the authors identified patients who were at risk of the risk of cancer is equivalent to age-matched population. Thereby, you can just justify discontinuing any surveillance in patients with branch duct IPM. So this was a multi-center study where patients with presumed branch duct IPMN and without worrisome features or high-risk stigma disease who underwent surveillance formed the study cohort. Clusters of individuals at risk for cancer development were defined according to cyst size and stability for at least 5 years, and age-matched controls were used for comparison using standardized incidence ratios for pancreatic cancer. Of 3,844 patients with presumed branch duct IPMN, 22% developed a worrisome feature or high-risk stigmata at surveillance of 53 months, and 4.3% underwent surgery. Of the overall cohort, 42% remained stable without developing any high-risk feature for at least 5 years. The authors stated that in patients more than 75 years, the standardized incidence ratio was 2.33, and in patients more than 65 years with stable lesions less than 15 millimeters in diameter after 5 years, the standardized incidence ratio was only 1.77. So the conclusion is that surveillance discontinuation can be justified after 5 years if the cyst is stable in size in patients who are more than 75 years and the cysts are less than 3 centimeters in size, and also in patients 65 years or older when the cyst size is less than 15 millimeters. So this study is very important because it gives you criteria when cyst surveillance by EUS can be discontinued. The next study is a multi-center blinded validation of the diagnostic utility of cyst glucose and amphiregulin to differentiate between mucinous and non-mucinous pancreatic cysts. 292 cyst samples with surgical histology obtained from multiple centers were sent to a central site for blinding. The blinded samples were used to measure cyst glucose and amphiregulin. Cysts with glucose less than 50 were classified as mucinous, and cysts with amphiregulin greater than 112 were classified as mucinous. The primary outcome was to determine if glucose or amphiregulin could differentiate mucinous or non-mucinous cysts. Results. Glucose differentiated mucinous versus non-mucinous cysts with area under curve of 0.88 and sensitivity of 90% and specificity of 78%. Amphiregulin differentiated mucinous versus a non-mucinous cyst with area under curve of only 0.60 and sensitivity of 65% and a lower specificity of 47%. CEA was used as the basis for comparison and had an area under the curve of 0.92, sensitivity of 60% and specificity of 9.6%. So the take-home messages: glucose demonstrated high diagnostic utility to differentiate mucinous from non-mucinous. Glucose had a greater sensitivity, whereas CEA had greater specificity. So for recap for this session, direct endoscopic necrosectomy at index session compared with step-up approach significantly reduces number of re-interventions to achieve treatment success and decreases length of hospital stay in patients with infected necrotizing pancreatitis. Permanent transmural double pigtail plastic stents after pancreatic fluid collection resolution is safe and superior to standard stent removal, reducing the risk of pancreatic fluid collection recurrence and re-intervention. EUS-guided liver biopsy does not appear to perform as well as percutaneous or transjugular liver biopsy. In patients with branched IPMN, surveillance can be discontinued after 5 years of stability in patients older than 75 years with cysts less than 3 centimeters and in patients 65 years or older who have cysts less than 15 millimeters. Glucose demonstrated high diagnostic utility to differentiate mucinous from non-mucinous. While glucose had greater sensitivity, CEA had a greater specificity. The next section looks at third space obesity and ESD abstracts. The first study is looking at gastroesophageal reflux and its sequelae after POEM procedure. This is a retrospective analysis of POEM data over 10 years. Per protocol, follow-up visits after POEM took place at 3 and 12 months and every year thereafter. And this workup included upper GI endoscopy, high-resolution manometry, 24-hour pH monitoring at 3 months. Endoscopy was repeated at 2 to 3 years intervals and at 6 years after POEM. The principal outcome was reflux esophagitis with complications and GERD symptoms and need for PPI use. 361 out of 522 POEM procedures underwent 24-hour pH monitoring. Abnormal acid exposure was detected in close to 50% of patients. Reflux esophagitis and high-grade esophagitis was detected in 41% and 4.6% at 3 months, 35% and 2% at 24 to 36 months, and at 20.5% and 0 at 6 years after POEM. PPI were taken by 52%, 47%, and 56% at 48, 62, and 72 months after POEM. There were no cases of Barrett's esophagus or esophageal cancer. And there was also no relationship between these findings and the technique of POEM. So the authors concluded that the rate of post-POEM reflux esophagitis decreases over time. However, 50% of the patients will require long-term anti-secretory. The next study looked at endoscopic sleeve gastroplasty with anti-obesity medications, and it analyzed combination therapy and its impact on optimal timing and age. For background, while efficacy of endoscopic sleeve gastroplasty and anti-obesity medications have been established, the effect of combination therapy and the timing for combination are unknown. In this single center retrospective study, patients were categorized to three groups. One, they either underwent only endoscopic sleeve gastroplasty without anti-obesity medicines, or they had a combination treatment of sleeve gastroplasty with anti-obesity medicines prescribed within 6 months prior to or after sleeve gastroplasty. And finally, sequential therapy, where anti-obesity medicines were prescribed greater than 6 months prior to or after ESG. The outcome was percentage of total weight loss at 12 months. Success rate was greater than 10% total weight loss at 12 months and serious adverse events. Of 224 patients, 34%, 31%, and 35% underwent monotherapy, combination therapy, or sequential therapy. Among combination therapy patients, 30% were prescribed a regimen that included GLP-1 receptor antagonist. In sequential therapy group, 81% were prescribed medications first, which is greater than 6 months prior to ESG, while 19% underwent ESG first, and after 6 months, anti-obesity medicines were prescribed. At 12 months, patients in ESG and anti-obesity medication combination group experienced greatest weight loss compared to monotherapy and sequential therapy. Patients started on anti-obesity medicine first, followed by ESG after 6 months, experienced least weight loss, while 100% in the sleeve gastroplasty and anti-obesity combination group experienced greater than 10% total weight loss at 1 year. Only 56% of anti-obesity medications followed by ESG sequential therapy reached this threshold. The rate of adverse events was less than 2.6% and was similar between groups. So the authors concluded the combination of endoscopic sleeve gastroplasty with anti-obesity medicines is superior to sleeve gastroplasty alone. The optimum time to add this medicine is within 6 months of ESG. Being on anti-obesity medicines for greater than 6 months prior to ESG was a predictor of poor treatment response for sleeve gastroplasty. This study looked at endoscopic submucosal dissection in IBD patients for visible dysplasia, and this was a French retrospective multicenter study. And they looked at to assess short and long-term efficacy of ESD for visible dysplasia in IBD patients. This was a retrospective multicenter study including consecutive IBD patients who underwent ESD with any visible dysplasia. The primary outcome was R0 resection. 89 lesions in 83 patients were resected, out of which 20 had Crohn's disease. The mean follow-up was a little more than 2 years. The median IBD duration was close to 20 years. 50% were UC patients, classified E3. Among Crohn's disease patients, 68.4% were L2 and 26.3% were L3. En-bloc resection, R0 resection, and curative resection were achieved in 91%, 80%, and 77.5% of patients, respectively. One patient required surgery for a complication encountered during the procedure. 3 for ESD failures, and 6 for bad prognostic histologic features underwent rescue surgery. The traction method for ESD was used in 53 cases, and it provided the highest en-bloc resection rate, particularly for large lesions and fibrotic lesions. High volume centers performed larger and faster ESD procedures compared to less volume centers, and were also associated with less recurrences. Recurrence was more frequent in Crohn's disease at 26% than at UC, which was only at 3%. So the authors concluded that en-bloc and R0 resection in IBD dysplasia is close to those obtained from ESD or sporadic for sporadic neoplasms. However, the risk for perforation was higher, confirming that more complex lesions should be reserved for high volume treatment centers. For session recap, the rate of post-POEM reflex esophagitis decreases over time, with approximately 50% of patients requiring long-term PPI treatment. Combination of sleeve gastroplasty with anti-obesity medicines is superior to sleeve gastroplasty alone, with optimal time to add anti-obesity medicines being within 6 months of sleeve gastroplasty. N-block and R0 resections in IBD patients is close to those obtained from ESD for sporadic neoplasms. However, the risk of perforation is higher, as much as 15%. We'll now move to the last section, which is luminal GI. In this session, the first abstract compared the management of variceal outcomes in management of variceal bleeding between endoscopic variation ligation technique versus TIPS and balloon occluded retrograde transvenous obliteration or BRT. This is a study from the National Inpatient Sample Database in the United States. And this sample was used to identify cases involving gastrovaricose hemorrhage, and they were classified based on the type of intervention: endoscopic techniques versus TIPS and BRTU. 7,160 hospitalizations with primary diagnosis of gastric variceal hemorrhage were included. Variceal ligation was performed by endoscopy in close to 70%, TIPS in 8.72%, and balloon occluded retrograde transvenous obliteration in 5%. The median age of patients was approximately 60 years and median hospital stay was 5 days, with the TIPS cohort requiring the TIPS and BRTU cohorts requiring the longest hospitalization. Also, the median hospitalization charge were highest for TIPS and BRTU compared to endoscopic method. Mortality also was highest in the TIPS cohort, followed by BRTU, and least for endoscopy-based techniques. Hospitalizations for patients undergoing TIPS had a higher association with inpatient mortality than endoscopic method. So the conclusion is that patients undergoing TIPS and BRTO have high inpatient mortality, longer hospital stay, higher rates of complications, and more hospital charges. Therefore, endoscopy is the preferred approach when possible in patients with gastric variceal hemorrhage. This study looked at artificial intelligence enabled computer aided detection assistance or CADI for colon polyps in the community setting, and this was a multi-center randomized trial. To provide a background, the authors evaluated the use of CADI in colonoscopy in community-based non-academic practice. Patients in 4 primary care endoscopic centers were block randomized to undergoing colonoscopy with or without CADI. The primary outcome were adenomas per colonoscopy and adenomas per extraction, which was defined as percentage of polyps removed that were true adenomas. 769 patients were enrolled. 387 underwent CADI and 382 underwent conventional methods of screening. There was no significant difference in adenomas per colonoscopy between CADI and non-CADI groups. Adenoma detection rate and serrated polyp detection rate were also similar between the groups. However, the withdrawal time was significantly longer for CADI compared to non-CADI patient group. The authors concluded that in this first prospective multi-center study in non-academic centers, use of CADI did not result in a statistically significant difference in the number of adenomas detected. This study looked at analyzing the use of savory dilators for empiric dilation in dysphagia after a normal EG. To provide a background, the authors assessed outcomes of empiric esophageal savory dilation in patients with non-obstructive dysphagia. Patients who had EGD for dysphagia over an 11-year period and underwent dilation using wire-guided savory dilators from the study group. Patients with obstructive dysphagia or known esophageal motility were excluded. This motility were excluded. The primary outcome was improvement in dysphagia, and the secondary outcomes included admission within 12 months related to dysphagia or food impaction, change in weight, and post-procedure adverse. 132 patients were included, with median age being 64, with majority being female. Median size of the dilator was 19 mm. 55% of the patients reported improvements in dysphagia, 15% reported no improvement, and 32% were lost to follow. Also, 56.2% were noted to have gained weight at 9 to 15 months of initial dilation. and 43.8% lost weight, but majority was not significant. 76.5% of patients did not have additional dilation, while close to 25% required at least one additional dilation. No adverse events were noted in any patient. So the authors concluded, given that most patients experience some improvement in dysphagia, and given the lack of adverse events related to dilation, empiric esophageal dilation using wire-guided savory dilators is safe and can offer some benefit in patients with non-obstructive. The last study looks at meta-analysis of dye spraying chromoendoscopy compared with high-definition white light endoscopy in inflammatory bowel disease related colorectal cancer screening. To provide a background, the authors evaluated the efficacy of high-definition white light endoscopy versus dye spraying chromoendoscopy in detecting dysplasia. This is a systematic review of literature of over 5 years. The primary outcome was proportion of patients identified with dysplasia. Secondary outcomes were proportion of patients with high-grade dysplasia as well as colonoscopy duration. And authors performed analysis looking at both randomized and non-randomized trials separately. In randomized trials comparing conventional white light endoscopy versus chromoendoscopy, dysplasia was detected in 19.6% and 12% respectively of patients undergoing chromoendoscopy versus high definition white light endoscopy, with a trend favoring chromoendoscopy, but it was not statistically significant. Among non-randomized trials, chromoendoscopy was significantly more effective than white light endoscopy in identifying dysplasia. When assessing for high-grade dysplasia, there was no difference between modalities in both randomized controlled trials and non-randomized controlled trials, and chromoendoscopy was associated on average with 6 minutes longer procedural duration. The authors concluded that non-randomized controlled data suggested a robust benefit for chromoendoscopy over high-definition white light endoscopy in dysplasia detection, whereas this was not true in randomized controlled trials, where only a marginal benefit was found in favor of chromoendoscopy. So to recap, the overall outcomes for management of gastric variceal bleeding by endoscopic methods is superior, to TIPS and BRTO. Empiric esophageal dilation using wire-guided savory dilators is safe and can offer benefit non-obstructive dysphagia in approximately 50% of. Finally, non-randomized trials suggest a robust benefit for chromoendoscopy over high-definition white light endoscopy in dysplasia detection, whereas randomized controlled trials suggest only a very small marginal benefit. So thanks for this opportunity to Dr. Reddy and the Asian Institute of Gastroenterology.
Well, friends, thanks, Shyam, for an excellent presentation. It involves a lot of hard work to pick up those select articles that are relevant, really, and more so relevant to the. It has become very difficult up in the experts like that. With that, now we come on to the next important part of it. That is the panel discussion. The six of these experts sitting Uh, let's take them one by one. There have been a lot of, a lot of good abstract, common questions need to look at that. I'm just presenting the what paper is here. Sham is already done. That is the permanent transmural double pick. Have always been that should be put it is required. Does it prevent the recurrence? So what is your comment on this particular paper to supplement what is your experience? To have some data on that, that it will be have a points of the.
Thank you, sir. Thank you for giving me this opportunity. I think I remember a paper from AIG which suggested that even in the large walled off collections, we don't have any benefit of putting a double pigtail stent after a removal of a large metal stents. However, probably the truth lies somewhere in between. I don't think every case requires the thing. We know that the possibility of recurrence is higher if there is a disconnected pancreatic duct syndrome. And we may have some clue to the presence of disconnected pancreatic duct syndrome, which is underestimated normally when we are doing an MRCP. And then probably a subgroup analysis can give us the right selection of cases where this needs to be placed. This may be something like a very large pancreatic fluid collection or walled off necrosis, or those are multiple, maybe some subtle signs like dilated pancreatic duct in the upstream pancreas or an acute angulation of the duct at the insertion. These are some of the things which may hint us that there might be a disconnected pancreatic duct syndrome. And in that case, probably a placement of double pigtail stent may help. I don't think we can universally say that every patient of PFC should undergo a double pigtail pancreas.
So the other panelists, guys will like.
I think the key thing is to, diagnose that this is a disconnected pancreatic duct syndrome. That's the thing. You put a metal stent in a walled off necrosis, and now you want to, decide whether you want to put a indwelling lifelong plastic stent, and you need to do a good MRCP. The problem is with the MRCP. Sometimes the MRCP may not be that good to really diagnose a DPDS. That's the whole problem. That's why I think they do even secretin enhance sometimes to really get to the diagnosis that this is definitely a DPDS. And if it is, then of course, putting plastic stent.
Before you answer that, you see, secret is supposed to be giving answers. But we have been talking about that for the last 30 years, but we never come to India.
So
do you think
we can get it self? We can get it from. Second thing regarding important debate that goes on what to do. Longitude studies now. That and endoscopy. I think Sham has that paper. For people have a disrupted all person are venting term with plastics. Majority of that not result in a pancreatic collection. Depends upon height of the collection. Suppose for height of the disruption, if head region may require probably tail region. But more important consequence, diabetes. Have disruption in diabetes, tail region. Second paper came study which that showed that the tendency toward time increase because we don't. So the conclusions from what we had experienced were are of the head region plastics. It also depends. Example, likely of can't generalize like Raj was saying. All patients, I think we had some dam also. Patients, small amount of the tail region.
So Shyam, what is your final? I mean, this paper shows us it is safe, but it doesn't show us which patients require it over long term. So what is your take as an expert? You are the prime worker in this area. Your personal take.
I think the evidence now speaks for itself. I think there has been a meta-analysis published last month. I don't think it's published, it's still online. They've looked more than at 1,000 patients. And it is quite obvious that if you have a disconnected duct, and then if you just remove the stent and you don't do anything about it, and if you give it time, then there's always a recurrence. The question is, what percentage of these recurrences are clinically relevant and symptomatic? I think Nagy's study, in all fairness, does tell us that recurrence does happen about 18 to 20% of the time. In fact, in their gut paper, the follow-up was quite short. It was about 18 months. And these things, you have to wait beyond 2 years for the recurrence to happen. So recurrence does happen. What percentage of them are symptomatic? We don't know. I think probably a third of the patients who develop a recurrent fluid collection may have some symptoms. Most certainly, the patients with a disconnection in the tail or the body of the pancreas don't need anything because that part of the distal gland will atrophy. That in the neck or the uncinate process probably are the patients that will require indwelling plastic stent. And I do agree with everybody that MRCP is quite unreliable. There is nothing better than doing an ERCP to get a reasonably good pancreatogram. And then I think that is probably the gold standard, given that MRI is not confirmatory.
So you are advocating prior to this ERCP, all those patients.
I mean, to be honest, the ERCP the MRCP in India is excellent quality. The United States, our MRCPs are not very good. So I don't trust MRCPs. I just do a ERCP on most patients.
Rajesh, quick word.
Just
Then we go to the next paper.
So taking this point further, we have Dr. Reddy has already studies which what we found that though there was a tendency toward more recurrence, those where we extent after removal of stents, but that there was not statistical difference. But we definitely found there is a less recurrence in the patient where we place the plastic. Second thing was we wanted to take it further. We want to see the site of disruption, which Dr. Reddy has already alluded. The second thing, residual parenchyma. If there is atrophy of the gland, the recurrence would be less. That is our hypothesis. If we are taking it further, we are planning a study on this issue.
Well, friends, it's a good paper. Watch out. Not that the final word has been said, but it definitely. Let's come on to the next paper. This is the surveillance for presumed branch duct IPMN pancreas, stability, size, and age. Well, Somil, what is your take on this thing? No, we see very few cases like that, but then this question remains whether you should be surveilling for 5 years, 10 years, lifelong, or what. Do you think this study answers this question?
So now with imaging, which is being done so commonly, especially CT scans and MRIs, we are picking up quite a few of these branching incidental cystic lesions, which we do see. And unfortunately, when they are size of 1 centimeter and above, that can cause concern and we need to follow them up. There have been several guidelines over the last 10 years. This subject is obviously still not well understood, and obviously all the guidelines don't say the same thing. We have European guidelines, American guidelines, Japanese guidelines, and there are differences with regards to how to follow up these patients. If you see the American guidelines, which came in 2015, at that time, Dr. Vege himself had said, in fact, his conclusion was the same, that after 5 years, you should stop screening these patients. But that was not said the same in the other guidelines. So what is being said over here is probably been already mentioned in a guideline almost 7 years back. And over there, age was really not a criteria. coming to this paper specifically, when they are using the word 75 years and above, I think this is a group where if someone has to do a pancreatectomy, even partial, these are very high risk patients. So obviously, most of the guidelines agree that if a person is not stable or fit enough, has got comorbid conditions, these patients anyways don't need surveillance. So I don't think so. A 75 years old person, I would really be too worried. 65 years plus, yes, I would definitely follow up these patients. And I think if the patient is clinically fit, I would probably continue follow up in these patients, if not every year, at least once in 3 years. And we should give this option to the patient rather than probably taking this decision ourselves. Because if a patient is aware that there is a cystic lesion there, and it can probably turn into malignancy in the future, theoretically, and that has been shown that even in branched duct, after even 10 years, there have been 4 to 5% of patients who unfortunately did develop malignancy. I think a patient should be given that option. That recommendations say probably no, but you have the option. And I think most of the patients, if they're affording an MRI, which is relatively safe, they would probably opt for a follow-up scan.
So practically what I understand from you, that it is not likely to.
Yes, as of now, yes, because we still need to understand the subject.
The panel. Shyam, do you want to add something?
I think we're, at least in the United States, this is a grossly abused cohort of patients. So we do at least 1,000 EUS in our practice only on pancreatic cysts. And the number of cysts that become cancerous, to be honest, is probably 1 in 1,000 or even not even that. So we are focusing a lot on pancreatic cysts. I think I do agree with Rajesh. I think it's important to look at the patient first and then to look at the cyst. If the patient is has got high comorbidity, then it really doesn't matter. We are not going to operate and at any point, and we should stop surveillance. And then we look at the low comorbid patient, and if they've got a high risk pancreatic cyst, sure, we should follow that. But if there's a low risk patient with a low comorbidity and having a cyst of like 5 or 6 millimeters, nothing happens. I think we can ignore them as well. So I think patient risk stratification is more important and takes precedence over takes precedence over a pancreatic cyst risk stratification.
We'll move on to the next paper. We have to discuss quite a lot, so let's. But now there have been difficult questions, arguments. Poem, Gerd, Mohan and Zahir both have published quite a lot on that. This paper tells us something about the gastroesophageal. A surprising thing tells us that with passage of time that this goes down. Your take, Zahir, on this answer?
I think
what are the apprehensions of the journal patients? Internet patients come prepared with this thing that this GERD is too much. Surgeons are ready to convince them. Go for it. What's your take on that?
I think now the evidence is gradually building up that the initial studies were regarding only efficacy. Next came GERD, and then POEM was criticized a lot that GERD is very common after POEM, but they were like short follow-up studies, and now we have enough evidence that GERD is definitely high, but it reduces with time. First. Second is severe reflux is very uncommon. For example, if we take grade C and grade D, LA grades, they are encountered only in less than 7 to 8% cases. So second reassuring fact is severe GERD is very uncommon. Third is what we are realizing now is, as Dr. Mohan has also worked on it, that pH studies, they overestimate GERD because there is a lot of acid fermentation happening. So probably the pH studies, what we are doing and how we are interpreting those results is probably inaccurate. And I think Mohan will further elaborate on that because we are probably overestimating GERD on pH studies. So right now the gold standard is endoscopy and not even symptoms because majority are asymptomatic. Now regarding the long-term follow-up data, so we have one study which we published a couple of years back that GERD reduces with time after POEM. Also again data from Winthrop University that reflux definitely reduces with time after poem, and this is in contrast to Heller's myotomy, where the reflux, if you follow them for 10 to 15 years, it increases with time. So I think this is very reassuring that GERD is not a major problem after poem, and even in patients whom you encounter GERD, it reduces as the time progresses.
We have Mohan here, for foremost experts on the subject, who's written elegant articles on the GERD in poem after poem. Mohan, what is your comment? And I'll also like to ask you that what do you think there's a need? Do you believe that could combining the poem with the endoscopic anti-reflux?
I think, thank you, Sham, for bringing this. And I'm really surprised to see 50% of patients requiring anti-cyclic treatment. And there is a gross mismatch, as you see, 47% pH positive and 0% grade C and D esophagitis. So that was what Zahir was also pointing out, that the automated machine which we use to interpret reflux in an aperistaltic esophagus, we are just extrapolating the data from a normal peristaltic esophagus reading onto aperistaltic. So everything acid exposure in esophagus is picked up as reflux. So 47% reflux positive in pH and 0% Barrett's, 0% CA esophagus after 6 to 7 years. That really brings to the point that we are not evaluating reflux properly in post-poem setting. We, as Zahir said, it is the Lyons criteria, which is type C and type D esophagitis, presence of Barrett's or presence of severe esophagitis, the only way where we can say that it is the reflux. We should not depend on pH metry, and over-treating these patients with PPI and fundoplication is not required.
The message is that GERD following poem is highly, highly overrated. Don't go after the lab or pH study. Go after the patient accordingly. That should stop you from going. That's what the experts say. Let's go to the next.
Yeah, Ajay, can you just
Yes.
make a comment?
Yes, I didn't realize that if we have a aggressive surgeon sitting here.
Actually, there are a lot of lessons that are learned from the endoscopy side. Actually, if you look at from the endoscopic perspective right now, almost about 60% of them don't require any anti-reflex procedure. Even on the surgical side, when we do this procedure, even after Heller's myotomy, about 10 to 15% of these people tend to have some amount of reflux. So the ultimate, the message seems to be that majority of these patients who are undergoing some sort of a myotomy do not require any anti-reflex procedure. The gold standard for doing a myotomy as on today, the objective test is just a cut. But you are making a cut based on the HRM. I personally believe an intraoperative or an intra-procedure HRM during the procedure will provide an answer to this, whether we require an anti-reflex procedure or not. Be it be a poem procedure or a Heller's myotomy, if you're doing an intra-procedure or an intraoperative HRM, and you have beautiful HRMs right now, which we can have a real-time cut that can be seen on the HRM right now. And I think if we can do an intraoperative HRM, I think this will find a solution to see which patients would require an anti-reflex procedure and which do not require.
Well, that's excellent. Very rare. Medical and the surgeon's minds working together to the right answer.
Can I make a comment?
Quick answer.
So I think 2 points. One is that, of course, many people in the West, they are doing it time. So we do the and then do the exposure to what is the not good enough. You can go into the that's really ready for poem. Second thing of most of the now doing poem are doing what is called anti doing two things. The myotomy. Myotomy. Secondly, are not doing the oblique, particularly in the oblique posterior. Are already doing what is called as so-called things are, I think, techniques are also.
So, good things are maturing as far as the understanding. So sometimes we feel that certain things are fully difficult, are challenged. One of these studies compared the pure cut or endocut for a biliary sphincterotomy, and to my surprise, it showed that here this particular study is advocating a pure cut. GB, you very much comfortable with a lot of surgical for the electrosurgery, and you are one of those surgeons who has a huge experience in ERCP. What is your take on that, theoretical as well as a practical?
Practically, Ajay, it looks like we have come back to where we started 40 years back. 40 years back, when we had just pure cutting current to do a sphincterotomy. But the biggest limitation those days were the fiber optic scopes and the analog systems, wherein intra-procedural bleed was worrisome. And we were worried about this, and that's the reason why they started combining pure cut with coagulation, and we started doing endocut. But over the period of time now, visualization has become better. We have better monitor. We are able to see the bleeds properly. And we have good energy sources to control bleeding right now. I think, and we have fair amount of experience with cold snare polypectomy right now, which shows that we're not worried about these bleeds, which can be controlled. I think it may be better to change over. And from the surgical perspective, they tried to combine these energy sources on the surgical side, and they found no difference compared to pure cutting or pure coagulating currents. So from that perspective, I think it's worthwhile to change over, maybe at least in select patients, to see if we can do a pure cut sphincterotomy in current day clinical practice.
Shyam, what is your take from this paper? I mean, you go by this or to change our practice?
I mean, Ajay, at least I've never used endocut. I've always used only a pure cut from my training days with cotton. So I've never understood this logic of endocut being used. It looked like people had a lot of concerns about bleeding and so on, but we all knew that pancreatitis was a problem with the endocut mode. So I don't have any experiences at all with using endocut. I think it's probably a theoretical exercise. Practically, everybody believes and thinks pure cut is the way to go.
Agi?
So a little contrary opinion. Problem of confound factors that is adverse time taken. Very so you change practices carefully. Physicians, I think because of these factors, one has to adjust taking all these factors.
This remains a point of contention before you change your practice. As I said, the conventional wisdom is challenged. So most of us will be practicing endoscopic approach is stepwise. Actually, this study has come from Shyam's unit. Am I right, Shyam? It's your unit?
That's correct.
Yes. Okay, Pankaj, this particular study trying to talk about on an index endoscopic intervention, that like endoscopic. What is your take on that? I think our setup. Had Sandeep's article on a stepwise endoscopic necrosectomy. Now you have this particular. What is your take? Comment, expert comment.
Yeah. So just to go just a bit back in time, the whole the step-up approach for infected necrosis, where they did a percutaneous followed by minimally invasive, and that's how the step-up approach. Then comes the era of the endoscopy. Endoscopy's approach came in the same way, came as a step. Transmural drainage with plastic system, and in those patients who did the tract. Now, come back in time and last couple of years, One is LAMS has come into. That's one thing which has. Plus, you have some devices which are coming. The moment this has happened, endoscopy and really invasive guys, they want to do everything. This is a real landmark, which I think it will be a landmark by group, where they are going to. They are telling us that now it's time to have access. We should now do hospital. The only flip side, is I would think to use it very often at the index session. You'll have to you'll have to dilate this, not be able to go. That I think is, and that in our setting, many times not using other lamps. That is an issue.
I'll be devil's advocate. Like I'll put it the other way. That if I do the number of patients will not require second intervention. So when you do intervention in the first go, then you need extra instruments. Be ready to control the for achieving hemostasis. Then thirdly, don't know how much to cover, how much necrosis to remove in one go. As a certain say, not important what you can remove, but you should important when you do open necrosis. It's important to know what you should. But in endoscopy, that will always remain a challenge. So after saying that, let's open it to any one of the panel or anybody from the audience. Did you want to say?
Definitely. One thing is, this is regarding lamps and the stents that we use, biflange metal stents. I think that is one of the reasons that we usually avoid doing necrosectomy in first session, because we feel that during first session the chances of migration may be higher. The other issue is regarding there is contrary evidence as well. A study published a recent study which says that probably delayed necrosectomy, the hospitalization and the number of necrosectomy sessions are lower. So as of now, it's a dilemma whether to go for necrosectomy right in the first go or whether you should do so. So probably we require a study which predicts the need of necrosectomy in these patients, whether this is the amount of necrosis. For example, the study by Mayo Clinic, it suggests that if a patient has more than 30% debris, if the collection is extending to parabolic gutters, and if it is larger than 10 centimeter, then these are the patients who require necrosectomy more often. Other patients can be managed without either doing a necrosectomy or by a step-up approach.
So, Zaid, what you have raised is exactly what as a point. Select your patient for what you need. That's my thought first. But Rajesh, you want to add something?
Yeah, I will agree with it. There are two technical. Is the technical challenge. One is the stent when you deploy, not fully open at first go. You have to dilate it and then go. The second thing, every patient doesn't require necrosectomy. Around 70%. So how to select those remaining 30% by necrosectomy or not? So that we cannot decide upfront. That's the reason. So we still feel the step approach is the better approach.
Just one point, I think Shyam's paper. I think Shyam, if I'm sick patients, infected necrosis. Is that the group you've taken?
Yeah, I mean, this is by definition, this is infected necrotizing pancreatitis. And the second inclusion criteria is you must have at least 33% necrosis in the collection. The extent should be 33%. And the quantity of solid debris within a collection should be 33%. That is one. Second is all the data will tell you, when you look at the whole collection of walled-off necrosis, then 70% will not need a necrosectomy. But if you are looking at patients with infected necrotizing pancreatitis with more solid debris, then the number is skewed. only 35% will not require necrosectomy. That is what the Panther trial had showed, and the Tension trial shows you that about 55% will require necrosectomy. So therefore, if you've got an infection, and if your necrotic debris is more than 30 to 35%, invariably you will land up doing an endoscopic necrosectomy at some point. Why should we stent, keep the patient for another 3 or 4 days, and then go back and then re-intervene in these patients because it's a big subgroup? The surgeons at a point, when you put in a drain, you want the tract to mature, you want to readjust the tract before you can put in before you perform ward. But in endoscopy, it's much easier. You just go to the stomach, you deploy the stent in the central aspect of the collection where there's a lot of liquid. And if you let the liquid to drain, and if you go after 3 or 4 days, like what we usually do, it gets more solidified and it gets more adherent and the procedure becomes more laborious. But if you go acutely in the middle of the stent, as soon as you deploy and you dilate it, the extraction process is easier. And second is we have used hydrogen peroxide. Now there are enough studies published in the Red Journal and a meta-analysis that shows you that when you use peroxide, it goes into areas of the collection where we have no mechanical access. It causes auto-debridement, that subsequent interventions becomes easier. So in this study, at least 20% of the patients did not require necrosectomy at all. On the step-up group, 80% required necrosectomy, 20% did not. But the main thing is that there was no difference in complications between the treatment groups. There was no death or in the direct necrosectomy group, and there was no increased adverse event. So therefore, given the low rate of adverse events in endoscopy, it does not hurt to go early and do it because you can get patients home faster and save some money by expediting recovery time.
Well, Shyam, that's what the advantage of the expert sitting here. What you can't see in the abstract is the details, that ultimately we are all of talking about the right patient for the right procedure, right approach, and it's not a universal select. We're all talking on. One paper on the gastric varices, I was quite surprised. You will like to say, I mean, do you justify in context? Your group is not even a part of a. Do you think this time for the fundal varices, does anybody do in India?
Here, Dr. Time really whether therapy anyway. Either the glue injection
So we go on to the next paper, which is very important. I want Pankaj to take up that. These are some unanswered common questions. This is a multi-blinded validation. I'm basically diagnostic utility. We have been hearing about Guru a long time. We have reached quick. We are running short of time. Quick answers. That today, if you do the system analysis, what all you will send for, and do you think?
I think it has added a lot because you are now giving a diagnosis of. Basically, you have to know whether it's a mucinous cyst. That's what is the main crux of the. Once it comes for you, so you have a endoscopy room test, the string test, and both available. Very high sensitivity and tell about a mucinous right in the. Plus, the volume of fluid required for glucose is 0.1 ml or something. Even if you don't have fluid, because if there's fluid, sometimes get 1 or 2 ml. Even if you just put your stillet and get 1 drop of, I think it's very useful.
Just 1 or 2. How do you check the serum? Cyst fluid glucose? Check it on the glucometer, or do you check in the lab?
No,
and
no,
what is there
glucometer.
any difference in the two? Is there a time gap between collection of the sample and testing? Does it make a difference?
So for the glucometer, you can do it on the glucometer. The glucometer doesn't detect very low levels. So it will not detect level less than 40. Just tell you low. That's good enough. I mean, tells you low, it's good. If you have enough fluid, maybe a discrepancy of 10
Shyam, what do you
milligrams
do
plus
in your
minus.
lab? Do you check the glucometer or you check?
No, Ajay, the magic value in the United States is 25. So if it is less than 25, then it is supposed to be pretty sensitive for mucinous neoplasm. We don't use a glucometer. I think it has to be standardized. So the standardized number is 25, and it is the same way that we do for a serological testing.
Agi, what do you use?
A study, and for us 40 is cut off. We also validated the lab quite good. So for us it's very practical. Maybe for legality purpose, lab.
But this everybody agrees that today's time, fist glucose is the best test. We can differ on the how to test it.
Sir, just a small point. It's that these values 25, 40, for example, glucose, same for CEA. So it's like the right balance between sensitivity and specificity. If you bring it down 25, it will be very specific, but the sensitivity is lost. So are we at the right values? Are we there yet that 25 and 40 are the right cutoffs? One. And for same for CEA. So CEA, if it's more than 500, then it's almost 100% specific. So I'm not sure whether we are at the right values, and we should still work on the values which have a balance between the sensitivity and specificity.
Sometimes certain technologies come and they are evolving. We think then they come, if they are fully established, before they are fully established, there is a setback with some study. And this is one of those studies which, Somil, I want you to address on a endoluminal RFA. That there was a significant data to show that it increases the stent. Of course, the data on the survival was, and there are always a different weight, whether it's cholangio or it's a CA pancreas. So what is your take home this particular? I think it here's the that this is the dead end for RF, Hepatobiliary RF, or
I remember seeing the first case which was shown by Professor Nagi only in one of his meetings over here, where he in fact even showed us a cholangioscopic view of what he had done over there. But I think even after that, I don't think so many centers in India is anyways doing this as of now as a routine. I would probably feel there are just probably
we
2
are
or
doing
3.
it.
So as of today, if you ask me, I think this group, most of the trials which were done in the past were all retrospective studies. And there were very few small prospective studies, but the numbers were very, very small. So I think this is probably a good study from that point, that the numbers are reasonably good. And they, as of now, say that there is no great advantage, but I think we still need subgroup analysis where probably take just pancreatic cancer, lower bile duct cancers, probably take Hyler, and then see if there is a subgroup of patients which really is going to be benefited. And then we can give the final comment whether it's out of the box. I think as of now in India, I think most of us still are not in the process of doing this.
Zahir, quick comment, Zahir,
Sir,
and then Randeep.
So we have to
sorry,
differentiate
Ramon.
biliary malignancies from non-biliary malignancies which are causing biliary obstruction. Studies, in fact, there are studies, randomized trials which have also shown that RFA is not effective, and in those studies, majority of the patients had pancreatic cancers, not cholangiocarcinoma. In studies, for example, the study by the previous randomized trial, where majority of the patients had cholangiocarcinomas or biliary malignancies, primary biliary malignancies, I think RFA had both benefits, survival as well as stent patency benefits. So it's important that we should homogenize the patient group when we are evaluating the efficacy of RFA. And those which are compressing from outside, probably RFA is not effective, as the energy where it's supposed to diminish the tumor cells, it's not that effective. If it is compressing from outside. This is probably the general belief.
Quick comment by Mohan.
So
and then
I think
Randeep.
we should compare this with PDT trials, which are very high quality trials and have shown survival benefit, and these exactly work of 3 to 4 millimeter burns. And if we include malignancy which are compressing from outside, will not be able to demonstrate benefit. So we should exclude patient with CA pancreas, CA gallbladder from doing RFA. And showing this not effective, it's going to be not effective because the technology is not working there. We have to include only intrinsic cancer of biliary system, then only we'll be able to.
I think there are two aspects. One is about the stent patency. Stent patency, biggest problem is that very few studies tell us what kind of stent they were using. With plastic stents, you're exchanging them. So you don't know that whether there's an increase in stent patency. If you're using fully covered stents, then ingrowth is not the reason for stent migration or stent occlusion. It's only the uncovered SEMs where you can actually identify whether RFA made a difference in stent patency. And a recent paper in GI endoscopy in June this year has actually shown that it did not affect stent patency or survival in both cholangiocarcinoma as well as pancreatic carcinoma. There's one important thing which we are missing is that none of these patients are going to be without chemotherapy or chemoradiation. And if you combine RFA with this, there is a definite evidence in 2 large studies of survival benefit. So I think we have to dissociate stent patency from survival benefit. Ultimate aim is stent survival benefit, and there it affects if you are combining it with adjuvant.
You made a very interesting point. It can.
Ajay, one question: can
Yes.
RFA avoid the stent completely? You're doing RFA for
I don't
humanization.
think anybody has addressed that question.
No?
I think one group has
It has been.
exemplary CA. I think we reviewed that paper. Inoperable, where they could avoid the stent completely, sir, in a substantial proportion of patients at the end of the follow-up. There were ampullary malignancies being dealt with the RFA.
Yes. Yes, Nitin.
So we have compared study on hilar cholangiocarcinoma, RFA versus SAMS, with SAMS and without with and without RFA. And we could found that at 6 months, hazard ratio is beneficial for stent patency at 1.86, and for survival at 6 months, it's around 2.89 for hilar cholangiocarcinoma.
Yes.
Of the bile duct.
Has anybody addressed it?
Yeah, I think this question has been addressed in some papers that after the RFA, they would do a balloon sweep to remove all the necrotic tissue and then place a stent. So this has been
again the RFA type of RFA. RFA available and non-temperature useless. There's no RFA not because you're only burning the tissue. Just like putting heat there. What we have the temperature control RFA, that is what we do. So the temperature control approximately 75. So temperature from there's no point doing studies with non-temperature. Not going to, because the difference is if you do a temperature coagulative necrosis resulting in antigenic modulation of the cytokine, which is going to make otherwise what's the point of running a expecting
Absolutely new angle to it, Nagi. Good issue. So it means this technology is there to stay. It's not we can write it off just based on this study. Similarly, as I said, that the new technology is evolving. Last DDW, there was a paper from AIG and PGI about the US guided liver biopsy. Now we see a paper here that talks about that it's inferior to the percutaneous and the transjugular liver biopsy. What is your comment, Zahir, on this particular paper, US guided liver biopsy?
I think many more things. This is not new. I think Shyam has published a couple of years back in Gut that US guided biopsy is inferior with only about a quarter of patients getting adequate biopsies as compared to cutaneous where it was more than 50%. So, but there are a few things that we need to know before we conclude the results of this study. The technique that was used, because we know that wet section improves the yield, and with a better core and higher complete portal tracts. The other thing is the yield is very low in this paper as compared to the percutaneous and those arms. In contrast, our results, which was a multi-center study with PGI in another 4 centers, we could see that the complete portal tracts and the adequate tissue specimen, which is variably defined more than 20 millimeters, it's better with EUS arm. Our results are in contrast with other results as well as the systematic review which was recently published, including 5 to 6 studies, where it shows that again percutaneous is a better. I think with time we are improving the way we are taking use guided liver biopsies, and with the newer needles, the yield is probably better as compared to what has been shown in this paper. I think Shyam I would like to hear his comments because he had the first randomized trial from his group.
Shyam.
I think the liver biopsy with EUS is an American sickness like sphincter of body dysfunction. I think people in Europe and Asia are much more pragmatic. It probably takes you about $20 to take a 16-gauge needle, get a long tissue, and have it read by a pathologist. I think if you want to diagnose cancer, you got a pancreatic mass, and if you're looking at a small lesion, sure, EUS is very useful. Or if you're using EUS for elevated liver tests and you're looking for a stone, the duct is normal, maybe instead of sending to my hepatologist, it's okay. We can make a diagnosis, but I think the pathologists really tell us when we use a 16-gauge needle, they can stage NASH, and I don't know much about liver, but they can what do you say? They stage the disease and grade the disease, which they think is not possible very well with a 19-gauge needle. Leave alone the expense, sedating the patient, dropping a scope. At least in the US, the value of a US guided liver biopsy, if you come to the hospital, is about $11,000 when you add all the facility fee and the physician fee. You can only imagine what a waste of resources this is. That's why all the papers on liver biopsy primarily come from the United States and not in Asia or Europe. So I think this is an American problem.
Okay, good. Well, we can keep on discussing this. That time, I think I'll go to the last paper for today. It's running, getting sick. Ravi, this is an old thing that endoscopic smear papillectomy of ampullary adenomas. This tells us something about the resectability criteria and the pancreatitis predictors of that. Predictors are incomplete for them. What do you think? Does this study add anything to our existence? Help us in
by the paper. Same way in our practice, very infrequent. But I feel whenever there is a be done.
TB as a surgeon, what is your
Pancreatitis we have to see.
What is your comment on?
I think it is a very apt this thing actually. But whenever we do a piecemeal dissection, we don't get a complete histology actually.
They also commented on the CBD extension.
Yeah,
They talk about the later
now
spreading.
we have this endoscopic ultrasound. Actually, whenever we have any extension into the terminal CBD, the pancreatic duct, becomes mandatory that we take this.
Quick comments, then we otherwise close. Well, friends, you will agree that we had a excellent discussion, excellent papers, and some of them path-breaking, some of them challenging the accepted thing, but still some of them putting the roadblocks in the newer developing technologies, but still you realize that it is not the end of the road. And but I think it's always good to stay update and so look forward what is the future tells us about those technologies. Shyam, special thanks to you staying awake for so late in the night. What is the time there, Shyam?
4:10 in the morning.
Oh, okay. This is Sunday morning. Okay, thank you very much, Shyam, for sparing your time and adding to the knowledge here. And thanks to all the panelists for being very positive and stick to that.
The panelists for discussion. Just a one. I'd like to audience. I'd like to thank Zydus. A lot of correspondence, all these recordings done. Hard work. Well,
told in the beginning, I think it is one of the most useful exercises I attend at least. Need to continue it, but just discussing the format, I think the format in future could be what Professor Rubin had in his talk, where he was addressing questions, clubbing all the abstracts together, and then analyzing them, rather than discussing only individual abstracts and having different aspects, different messages. So I think that may be a discussion which can happen with the presenters subsequently.
Will agree with me that this was a very, but I agree with Dr. Randhir Su that the format now whole world, whatever or innovation happens, actually are presented, and everybody cannot go to the DDW. Also, DDW is a very busy meeting. There you miss a lot of things. There's too many parallels. This actually helps all of us to become tuned to what is happening. Not only it is useful for patient care, but also teaching, and very important in the research. So if you are doing research, what you need to know is that what is the current thing which you should. And one good sign that is happening in India now is a lot of private sector are getting. And in fact, in Indian Journal of Gastroenterology, when the editor, almost 60% paper were coming from private sector. And this is a good sign, because any country which has developed, it has never developed only with public undertaking, but it has been the private sector which has pushed it up further. And therefore, this is a good thing. Take it up for better patient, better teaching, and finally getting the cutting edge information.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे